infrastructure. Information that is given out is always need to know basis. For example, where my center is a coordination center for human security, there are other things beyond health. We also have determinants of health. And I give one example. In the northern part of Ghana, for example, there's, I think in the Boko Upper East region, I mean, there haven't been so much peace. There's some, unrest going on there. And this unrest is making teachers uncomfortable. So people are requesting to transfer, out of the place. It's making health workers uncomfortable because at the time that there's unrest and there's chaos, that is when people are likely to be hurt, for which reason access is critical. And that is the time that health providers who are also part of the population there are also running away. So at the end of the day, a security challenge becomes a health problem. People who need education to understand why it is not necessary to fight will not get it because the teachers are also scared and they are running away, creating a lot of problem for the community, social challenges, economic challenges, and what have you. So that is one part of it, that information that is always shared is need to know basis. So I think that you shouldn't, worry too much about. Everywhere in the world, nobody will tell everything unless you are a journalist and you feel that you want to say anything anyhow. The other one is also related to the funding. In Ghana, we do know that the government of Ghana budget will not be adequate to do everything that we are doing. So we also work closely with development partners. But I think in the past, we have a lot of NGOs that have come into the country to do one activity or the other, but it is not captured into the national budget. When I talk about national, it's not only the government of Ghana budget, but any other funding mechanism from wherever, including development partners. So I do know that now, development partners funding mechanism also ultimately must pass through Ministry of Finance, which has to be captured so that we know the total amount of money or funds that are made available to the country. Even with the Abuja Declaration, it may be possible that we may be spending even up to 20% of whatever fund it is. But if we do not capture every other fund from wherever it is, you may have a challenge thinking that you are not achieving what you intend to do. Now, the other one is also related to the capacity in terms of human resource and then the equipment and infrastructure. I must say that between 2020 and now, we have developed in higher percentages of human capacity because of COVID-19. For example, we had only 2 major laboratories in the country that were maybe biosafety level 3 or so. So Noguchi in Accra and KCC. When we started, samples had to be brought all the way from maybe Upper East, Upper West region, either to Kumasi or to Accra. But as I speak to you now, we have more than 100 PCR testing sites in the country, meaning that access has become easier. It's like, as he was saying, you could pick samples very close, RDTs are also available, at least to have a fair idea of whatever you are dealing with before samples are, sent for confirmation. So we've taken advantage of some of these opportunities as far as the pandemic is concerned, even in the time that we were threatened with Marburg's disease. That was the first time we never had it in Ghana before, but at least we're able to identify this. And then in terms of the preparedness, the detection and preparedness, and then response, all these things were. So we're looking at infrastructure that has improved so much. We're looking at the equipment, we're looking at human capacity. Day in and day out, a couple of simulation activities are going on, even across the borders and countries in Cote d'Ivoire, Burkina, and then also Togo that we are currently working with. So maybe I would say that when you did your presentation, yes, some of them are, I would say, like where we really want to get to. But I can confidently say that in the last 3 years or so, there's been a lot of improvement that we can see in the country in terms of capacity, even with financing. And luckily, maybe I'll say that in Ghana, we had what we call the COVID-19 fund, and we had the COVID-19 levy. So one of them was more related to private sector involvement and all. I know that people were even pushing for scrapping it off because at the moment, the COVID is not as we saw it in the past. But we're also developing the national health security policy. And then in that document, which we have opened it big enough, to address issues around One Health. Because we do talk about One Health all the time, but in terms of its implementation, has become a bit of a challenge. But I must say that we are developing a One Health policy, which is nearly ready. We have a One Health team that more or less is coordinating some of these activities. So we identify some, I think 5 conditions or so, including, let's say, anthrax, including things like brucellosis, trypanosomiasis, that, ultimately run between humans and animals. And these are some areas that we are currently working on. So for me, it is more evident as compared to the last 5 years. And these are real tangible things that we are seeing as far as preparedness and response is concerned. So what I would say is that in that national health security policy, we are pushing for an epidemic preparedness response funding, because now we are in an era of emerging and re-emerging diseases. It is also proposed that in this decade that we find ourselves, many more viral outbreaks and ultimately, into pandemics are going to come. So what are we going to do? Are we going to sit down until something happens? WAC even mentioned that the only way to address some of these things is to put systems in place that you'll be more proactive in your surveillance so that you can identify these things and then respond early enough before they get out of hand. So maybe I would say that in Ghana, health is politics, education is politics, agriculture is politics, governance is politics. You can't detach these things, but we have to work within that system and that scope so that, we can also position ourselves in that way. Thank you.
Thank you. Can I ask? Okay, please. Just to throw in, maybe you can also comment on this. So one thing is that Chico was also mentioning that they are thinking about working on is these clearer standards around data, so that we have greater uniformity. Do you think that would remove some of the politics? So when we say sort of health is political, sharing data is political, do you think that would remove some of those aspects? Sorry to ask a follow-up, and maybe you can also comment on it, Dr. Linda. Sorry.
Okay, thank you. I think that for those of us here, especially from Ghana, when the COVID came, reporting became a bit more transparent than probably in the previous years. If you look at what happened at the onset of the COVID-19, it was believed that probably maybe 3 months or 6 months before, and nobody knew about it. Even in Ghana, people were looking back and said, I traveled to one Asian country or the other around October. When I came back, I had a very bad flu or a cough, which didn't work. I mean, I tried every kind of antibiotic or every kind of medication until people became aware that, in December, a certain outbreak or something might have happened. And then people say, could it be that, 3 months ago, I had something like this or not? What I want to say is that we had a certain global reporting platform. And then for me, it is opening up a bit more for transparency as far as reporting is concerned. Hitherto, when the monkeypox came, Ghana was reporting and this data was picked up globally. When the Marburg came, we got one first case, we got 2 additional, and then 1 suspected, which was not. So we had 3 cases, and we were reporting all these things ultimately. When the COVID was also being updated, I mean, data might not necessarily be perfect, but in terms of the transparency, this data was reporting. So maybe it can also improve the transparency and then also the accuracy of that reporting. But I think where we are getting to, it is not possible to hide anything, because everything is staring us in the face. If you share that information early enough, then there is opportunity for us to respond. If you look at that epidemic graph in terms of when an incident happens within a maximum of 7 days, WHO has the 717, within a maximum of 7 days, if you are able to, report and then respond appropriately, then it's likely you can save a lot more people. But if you hide it, and it's an infectious disease or highly pathogenic something, there's nothing you can do by hiding it. It will obviously expose you when the mortalities begin to come up. So for me, I think that we are at a point where there's more transparency, and then you can't really hide a lot of reporting. Ultimately you'll be heading the direction of genocide if you want to hide some of these things. Over.
Yeah, thank you very much. I think Linda Butler has switched on the microphone, so please go ahead.
Yes, thank you very much. I would first want to reiterate the point made by Walter with regards to the data itself and how the data is as quality as the ones that we would want. Going back into the issue with how the data is collected at the community level with the community health volunteers. It's something that would be very important if we are able to regularize and standardize so that data is collected evenly. So with regards to the motivation aspect, yes, I am speaking from the research point of view. And as a researcher going into the community, and I'm into the NTDs, you realize that there are funding for the other disease. And so volunteers are highly motivated and they work in taking and collecting data for those disease conditions. And then it comes in with other diseases like the NTDs, and they are not, because they feel that they are not getting enough. If, for example, if I should compare filariasis with polio vaccine, for instance, they are not getting as much from the filariasis as they are getting from the polio. So the motivation goes down, and then the polio is setting a standard for the other diseases that might emerge, like maybe meningitis and other conditions. And then it is affecting the collection of data, resulting in under-reporting of cases for us to be able to eventually we don't get the true reflection. So if there's the possibility to harmonize all these disease conditions and not just align it to the funders as say, this is funded and this is not funded, so do a voluntary work for this one and this one you get input, they are not able to understand the system. So if there's a possibility of standardizing for them, maybe regularizing their activities, that will also improve the data that is collected. I also side with Dr. Ernest with regards to the data sharing. Yes, I attest to the fact that there have been major improvement. My only small issue is with communication and information, especially to other partners such as researchers on the ground, because you would want to collect a data and you are not aware that we have a standardized platform, and so you have to get these particular variables to be able to fit into the existing system, like the DIMS, for instance. So data had to be collected from the research point before it was realized that there's a particular framework that it has to fit in. And then at that point, there are some issues. So if there could be a lot of communication, more improved one with the researchers on the ground, that will be of immense help. Thank you.
Yeah, I was actually coming to Gordon, especially that he's been very much involved in sequencing, and the capacity for sequencing was also mentioned as one of the findings. So you have it.
Yeah, thank you very much. I think my general comment is that the presentation was very comprehensive and captured, I think almost all the issues that exist and the challenges that we face. In fact, like somebody mentioned, many of them we already know, and the governments know. I mean, everybody knows these challenges that exist already. The problem has been, how do you move from those challenges? And I think that's where the focus should be. How do we enforce the changes that are needed? We need a whole reorientation of the public health system, and that starts with defining the competencies of people in the public health service. And I think that's the most interesting part of the recommendations. We have to define the architecture of the personnel or of the workforce, and then we have to define the qualifications or the skill sets that you need in a public health force. both at the national level and the regional level. What we have in most African countries is a very old and outmoded system of public health. If you look at the qualifications of people who, or the criteria that they use to appoint people into the public health system, it's very old. They do not require them to even be able to use Excel or analyze data. So what you get mostly is people who have been in the system for a long time, who have practiced in the system. And you normally end up with people in public health, in the healthcare service, rather than people who are more research intensive or research oriented. So if we don't have a balance between people rising up from the care side of health and those who are coming from the knowledge generation side of health, you're not going to be able to bridge this gap because the mindset is different. The orientation is completely different. Okay. And modern disease surveillance is much more analytical and data intensive than practical care in the hospital. Okay, so we need to have a balance between these two in the kind of personnel or the workforce that we have. And that leads me to the next thing, which is something that was missing from the presentation, is the integration of the partnership between academia and the public health. That is very critical in bridging this gap, because we often hear that there's a skills gap, we need to train people. I can tell you that the skills exist, but they are in the universities. I have, master's students, PhD students that we churn out each year who have the skills that we're talking about. But based on the current system of employment, they would not get employed into the public health system because they are not a doctor, they haven't worked in the hospital, they haven't done, they haven't been a field worker or whatever. The qualifications are geared towards people who have been in clinical work. You understand? So we need to re-engineer this whole system and the mindset so that we are making use of the existing capacity that we have in our academic institutions and integrating that into what we have in the public service so that we get maximum benefit. The other thing I want to talk about is the issue about financial independence. Is absolutely critical in all this. People play to the tunes of who funds them. So we have a situation where the funding for health research or disease surveillance is fragmented because everybody gets funding from a different source. And so their mode of operations is more directed towards satisfying where they get their funding from. In more developed countries, there's much more centralized government funding for public health. So it means that there's more control of the health system than here. Here, like others have mentioned, most of the funding comes from outside. In the universities, most of our health research, in fact, in my lab, 90% of the funds we have comes from outside. We've sequenced 3,000 genomes. It wasn't from the government of Ghana. Government of Ghana didn't give us money to sequence those genomes. You understand? They don't even know where you got the money from to sequence the genomes. So it's difficult to integrate if the funding is so, or let's say varied and not coordinated, So these are some of the issues. Then the last point about the reagents or the supply chain issue, that's a very critical issue. This is something, again, everybody knows about. We've been talking about it for ages. I mean, you cannot do proper science when reagents take 6 months, three months minimum to turn around, So how do you respond when you cannot easily get access to reagents? And I think that, again, how do you address this challenge? This is more of a commercial problem. It's a political and a commercial problem. And it's difficult for those of us sitting in this room to address that because the commercial part is that the companies that sell reagents they are looking at their bottom line. So most of them outsource their rights in Africa to third parties. So if you want to buy reagents from Illumina, I cannot order directly from Illumina to do sequencing. I have to talk to somebody in Dubai or Nigeria for them to order the reagents and double the price, and then take 6 months to bring it to me. If I'm lucky, it comes and it's still cold. Sometimes it comes and sits at the airport and it warms up and doesn't work anymore. And then you start the process all over again. But Illumina doesn't care because, first of all, my pitches or my expenditure is very little in their bigger picture. So they don't really care what I think. You understand? So it's a commercial issue for them as far as the manufacturers are concerned. And then the political issue is that there's all these complications of importing reagents, and you know, customs is part of it, procurement processes are part of it. All these things are bottlenecks that politicians do not appreciate how much impact they have on our ability to do science and to do research in a very efficient way. Thank you very much.
Thank you very much. We take, yeah.
For me, also 90% of our money is coming from outside.
So it's not centralized.
But I think it's really makes a difference. We have that also with KCCR, that you need to establish import lines and import permits so that it doesn't take this long time. I think this is when I saw the slide about diagnostics and speeding this up, I was immediately thinking about all these problems that we are having, and that you're obviously also having, that the market is too small to leave it with market mechanisms. So there has to be other things that help in order to expedite the process. Otherwise, one will never be able to respond really fast. And if you had not made this argument about integrating research into the system, I would have brought it up, because I think it's really essential for everyone to stay at pace of the development. I give you an example of New England Biolabs. You may know that every senior researcher is the senior department head is obliged to have an own research project. Why is that so? Because they need to develop themselves. If they wouldn't develop, they would sell old products over the long run. So I think it's helpful for both sides. It gives the researchers an opportunity for translational issues that are of interest for policy, but also the way of thinking, of innovative thinking, is fruitful for the authorities, I think, and this is a very important point. So I think we had
just of time, we will take John and then take our brother, and then we will break for lunch, because some of the issues will be delved a bit more detailed and deeper in the next session. So for example, the next session after lunch, we'll be looking into data itself, a better data. So it's going to generation, sources, funding, and all these issues will surface again. So I'm not really starving you, only to hold on a little while after lunch with this. So John.
No, thank you very much. Just on a lighter note, Reinhardt was arguing that 90% of his budget also comes from outside. That I think we would begin to look at real numbers then, instead of percentages. But that's just on the lighter side. Yeah. But the point that you made, Gordon, is what I really wanted to hammer on, which is the sources of the funding. It then brings into question who owns the data, and then who is making demands of that data. Again, this is Chatham House rules, and so we can speak freely. We know the amount of energy we put into bringing the politicians here, and we can see the result for ourselves. I mean, they are not particularly interested. This is just a fact. KCCR celebrated our 25th anniversary. Where were they? You know, it was a lot of effort, but they just hardly showed up. And this is just a reflection, Ernest. I mean, I hope you would take this to them, that it can't continue this way. Otherwise, we will just keep on struggling and struggling. my friend Kofi Boni at Noguchi, who you know very well, has also been belaboring this point where the policy makers and others, when they realize the need for research data because of the demands that are coming from WHO and others, then begin to make demands of us, and yet wouldn't want to put anything into it. They demand the sequences, they demand and they send requests, oh, go and collect the sample, can you do the PCR, can you find the reagent to the PCR, can you sequence, give us the sequences, and even when there are forums for presentation of Ghana's data, they won't invite the technocrats. They will say, come and brief us, and we go and present. And I'm saying this openly, freely, with no recourse to anybody, because it's the facts. Okay, my friend, Dr. Sidu Bekoin, will be in very soon in the afternoon, and I hope to be able to put this to him very directly, you know. And we cannot continue in this way, Gordon, and you have a lot more muscle than I do. You should be shouting a bit louder, or maybe you are tired of shouting, but we really have to make this point. Well, anyway, we are in this together, and it's important that they recognize the tertiary institutions and research institutions as a highly responsible, independent technical arm that can do a lot of good for the ministry and for the research institutions. And that being said, and I believe my colleagues in other West African countries who bear me out, Ghana is better than many, to say the least. And the degree of censorship, somebody was supposed to come here from a research institute. He said that his travel permission had been revoked by the ministry because there was some function they wanted him to attend. Can you imagine? Here, we don't have that travel permission being revoked. We don't have that here. So others are even struggling more than us. Maybe we think it's normal, but it's anything but normal. And if we don't really put things in the right place and see how we can contribute, it becomes very difficult. And then, as my friend Kofi Boni will say, sometimes you get tired. They ask you and say, my friend, I won't give you all. Look, and then the researchers are no longer willing to collaborate or to support because it's like there's nothing, no acknowledgement. You don't know where this is going, don't see any results from it. So there's a lot of work to be done. And I'm hoping that given the authenticity of this meeting, this can be a very strong point, which I believe, Johanna, your institute together with the Pandemic Hub can amplify and really make it loud so that this point resonates and hopefully it will engender change. Thank you.
Okay, thank you. I want to go back on the data is political. I think that here we have two issues. In my country, at the country level, talking about the COVID-19, I think that there we have a kind of leadership problem between clinicians and epidemiologists in sharing data. And for reporting diseases, I'm wondering if we don't have a problem with the strength of the international health regulation in constraining countries in reporting diseases, because maybe for political issues, some countries they refuse to report some diseases. We had a problem with monkeypox in Cote d'Ivoire in last month, and the country wasn't able to report. And maybe it's a problem with the strength of the international health regulation. Thank you.
I think it is good to give you the final opportunity to remark.
Okay, thank you very much. So again, I think around the data collection, my colleague also talked about some of the gaps. I think there are opportunities for stakeholder identification to make things work better. I think again, when we had the the 5-year program between COICA, CDC, and Ghana Health Service. We're wrapping up. Then I met Dr. Owusu, where he also noticed that I'm no longer in the Ministry of Health, but there's a new center that has also been set up. It takes a bit of time for everybody within the space in the public health and the clinical setting to know who is where. But again, we are, from our side, we are also trying our best to identify all the stakeholders because of the role we are playing as far as coordination is concerned, because we don't provide response, but then to be able to identify all the stakeholders in the space and then to be able to do that connection as far as response is concerned. So I think one of the gaps is that, yes, truly, we do not know. And likely we may be duplicating some of the efforts, or sometimes we may even be antagonizing some of the efforts that are happening. But for this platform, for example, is a good opportunity for people, for us to know other organizations that exist and what we can do between service delivery, where Chag, Dr. Dua is coming from, and then academia. And so from there, it's easier for us to connect. The other one, as in terms of the consolidation of the various programs, we do know that we have these vertical programs, and because of the funding mechanisms and the reporting lines, that is what sometimes also creates a problem. But if we put our systems in place before a funder comes on board, then we'll be able to say that, yes, we want to have a consolidated system. Not that you come and manage only HIV. Now we have HIV, TB, at least together. Then somebody says that mine is on polio. And then, as you rightly said, there's a lot of funding around it. But even the name for neglected tropical disease is neglected. Nobody wants to go there. And I think last week or two, there was another West African program, ECOWAS program, where they are even looking at even the name neglected. Because if it's neglected, nobody wants to go there. And we keep drumming that nobody is minding the neglected, and it is still neglected. So nobody, but then also, these are also great opportunities for us to look at some of. The last one is also related to the funding. I think sometimes it's also about accountability, and then also declaring what we have. By and large, the research institutions, when they receive funding, like Dr. Prof was saying, the GOG is not aware. And also maybe we don't declare, and that is why the Minister of Finance is now wanting to know whatever is coming from them. Because if we haven't provided you any funds and you are working, in quotes, you receive all these funds because of Ghana. And I remember one day I went to see my chief director. Again, I just want to be very frank. And I said, oh, chief, this work, this request that we are making, the money is not coming from the government. Oh, we got it from somewhere. And said that if you were at home, do you think that that funder will come and fund you? The funder is funding you because you are working in the Ministry of Health. So that money is still Ministry of Health money. You see, so I think for me, it's also about accountability. If we work closely enough, and then also to be able to declare, even the government will know that, oh, really? So all these things that WAC is doing, so they are receiving the money from somewhere, we are not doing anything for them. And then we know that the 90% is coming from somewhere, and then we may be able to contribute something. But if we are not funding, things are working and it's in Ghana, then Ghana is doing well. The politician is very happy to enjoy the glory that is associated with it. So again, I think that it's also another very important, especially for even the NGOs, the CSOs that we've been working with. Everybody is hiding doing something. Then tomorrow they just need a small platform to come and say that this is what we have been doing in that community. Nobody knows how much money has gone into it. They are receiving their funding, creating the impression that everything is always so bad as far as the data is concerned, so that they need some funds to also improve. So for me, I think that transparency, openness, and then accountability is also important to also push the politician to do what they ought to do. I have taken notice of a lot of some of this information. We do advocacy to the government, not to the public. So whatever we find, open source, closed source, we wrap it up and say that government, this is what we have been able to find in the community as the problems. Could you please, because we have that response option, could you please work on A, B, C, D? And then over the period, we can also evaluate and say that we remember that 5 months ago, 6 months ago, these were some of the challenges that we saw. We have done the evaluation, nothing has been done. We are bringing it to your attention again. But of course, everybody and you cannot twist the hand of the government, whatever they should do. In any case, all of us find ourselves in the government one way or the other. Thank you. I'm becoming like a politician, but I think that's the reality.
Yeah, thank you very much for these comments. I think for the sake of time, I would now say we close the session and continue maybe over lunch with some additional comments, and we will go in more depth for the afternoon. Thank you very much for these really strong comments, and I felt there's a lot of heart blood in there, and this is actually what we want. This is why we wanted to create an open forum where we can say what we think and get into discussion. Yeah. Time for restart. I hand over to Daniel, I think, for that.
Yes, so we will start the next session at 2:15. We do the 2 o'clock, so we have rather 45 minutes of lunch break instead of an hour. So 2 o'clock, sharp. Yeah, it takes us to 5 minutes to walk there, so 45. Yes. Okay, so see you all starting at 2.
I was going to say we have.
Good afternoon, everyone. Welcome once again to the second session of the program. And for this session, we have an important guest in our midst, and we will need to introduce him for him to give us a short remarks, maybe in about 5 minutes. Then we can go on with the program. So we have with us here Dr. Franklin Esiodobokwen. Is a medical practitioner and public health physician with specialization in applied epidemiology and disease control. He's a fellow of the Ghana College of Physicians and Surgeons with over 20 years experience as public health practitioner. So he's the director of public health in Ghana and in charge of all the activities, ensuring that our response system in Ghana so I would like to invite Dr. Esiodobokwen to give us a short remarks.
Thank you very much. So I'm sorry for not being here this morning. So I think we are fighting a pandemic, but there's also an old pandemic. HIV is there. So today is World AIDS Day, and we had to go and commemorate it at the State House. But I think that it's good that we have such meetings. The world is still going to experience more pandemics because we have so many unusual events going on. The idea is what capacity exists for us to early detect. I think the key word is about early detection. The detection will come, but it's how early is it? Because that one averts the burden of the disease. So how prepared are our countries? And I think that globally, the IHR was supposed to give us some protection. Somehow when COVID came, countries had to explain it in their own dimension based on their understanding of it. So I think that on Saturday, we are going to this meeting in Geneva. It's about the IMB, the Intercontinental Negotiating Body. The thinking is that the world needs to be binding on member states so that people can actually conform to ensure that safety in Ghana assures safety in Germany and safety in Nigeria. So as practitioners, I think that we need to understand the context in which we are operating. If you look at Ghana, I would say that the COVID, though it has been challenging and disruptive, has brought about a lot of improvement in our preparedness. I mean, in all areas of health security, for port of entry, for surveillance, for case management, for risk communication, for even infection prevention and control. There's an obvious improvement. I think that we are not there yet, but clearly you can see that there's an improvement. The joint external evaluation gives an idea of how countries are prepared to address emergencies. But I think that was not so instructive when we had the COVID. We as a country want to actually do a repeat of our joint external evaluation to see how much we have progressed over the past 5 years. I think one thing that we also need to be talking about is this concept of One Health. I keep on saying that at times it's One Health and we are looking at sectors who are circling together. But at times when we try to break down the components, we realize that one sector appears more pronounced than other. And I think that let's get equal representation from the sectors to make money out of it. One big challenge has been data sharing. I think that is a challenge not unique to Ghana. I think Kenya tried to address it by forming the zoonotic division unit. But even Ghana didn't really do much. So how can we share information? So I think CISI helped Ghana to come out with this prioritization of zoonotic conditions to help us improve on data sharing. I think that we are trying to work on it, but it's still a big gap. Just last week, we had this PVS and IHR meeting to try and bring variety about how the sectors can work together. Prior to that, we had this bridging workshop using rabies as a proxy, all in the idea of ensuring that collaboration works between the sectors. I think that the sectors are somehow independent. How do we ensure that they work? I think that so as experts, let's see how best these things can be real, because you can talk around it, but in practical sense, it becomes a big challenge. We are trying to come out with our One Health policy, but I think that we developed it before the COVID. So I think it's about time we review it before we went about to launch it. So those are the current challenges that we face as a world. It's a world of uncertainty now. So I think the key issue is how sensitive is your surveillance system, because the unusual events will keep on coming. But the sure way is how early to detect to minimize the effect on your systems. So I want to welcome all of you to Ghana and to Accra in particular. And then let's see how best this meeting will add to the knowledge that we have in Ghana. And very much appreciate your presence here. Thank you very much.
All right, thank you very much for the statement. We are now going to dive deeper into the real issues of the data availability, data reliability, what data should be needed, what are the data gaps. So after the morning session has really laid out everything, and we have heard from G-WAC and from Anne what are the problems in all these areas related to data analytics and decision making. We now take these three things separately, and this is the first session to look specifically at the data. And some things we have already heard in the morning was like the fragmentation of the data related to the different funders for data who then own the data and the problem of sharing the data. And we also heard about the problem that data is being reported up but not being reported back down, and that people on the ground don't know why they have to collect this data. And that is of course problematic, because then they don't collect this data in good quality. And we also heard about like the problems with incentives for data collection, in fact, and that this may skew the data collection in certain areas and limit data collection in other areas. So we now have for this session first two presentations. One by Benson Droty, who is the head of health information systems at the WHO African Regional Office, and he will give the first presentation on health information systems in the African region. And then we have Mirawi Aragon from the Africa CDC, who is the head of division of emergency preparedness and response at the Africa CDC, and he will speak more about data sharing more with the focus on epidemiological surveillance. And with that, I hope Benson is online. Can you hear us, Benson?
Yes, I'm here, William. I'm
Perfect.
online.
I'm very happy that that works out. So with that, I would hand over directly to you. And then after that, we will, so after the two presentations, I think we will have the presentations one after the other for about, so it's 15 minutes each presentation, and maybe with brief questions if there are questions for clarifications after the presentation, but otherwise we have the discussion and the reflections from the country's perspectives after these presentations, so that they could reflect on the problems that are being presented as part of the presentations. So thank you very much, Benson. I hand over and I already see your slides. So that's very good. They are not yet in presentation mode, but I can see the slides.
Okay, so just help confirm if you sit on presentation mode.
Yes, we sit in presentation mode now. Thank you.
Okay, can you hear me clearly?
And we can hear you very clearly, yes.
Excellent. Thank you so much, William. And first of all, thank you so much for your kind invitation to participate in this first biennial West Africa Policy Dialogue on pandemic preparedness. As you know, I should have been with you on the ground. Unfortunately, I did have other commitments, so I couldn't really make it. Luckily enough, we do have technologies that allow us to still continue to engage. You asked me to talk about data reliability as a basis for disease surveillance and pandemic preparedness. So that's exactly what I'll try to do. Again, just to introduce myself a little bit more, my name is Benson Brock. I coordinate WHO's work on health information systems in the African region. I'm based in Brazzaville, that is in Congo. The WHO Africa region has 47 of the 54 countries in Africa. So most of the countries that we cover are based in sub-Saharan Africa, which actually bears most of the challenges associated with data availability and quality. This is the outline of my presentation. I will give a very brief introduction, focusing specifically on why it is important to have reliable data for disease surveillance and pandemic preparedness. I will also talk about the key sources of data for disease surveillance. I would mention something about the current state of health information system in the African region. I talk about the key issues and challenges with data availability and reliability, and changes that countries need to make to improve the availability and the quality of data in the African region. I will end on an important note on why it is important for countries to have one common data approach. Much as I'll be talking a little bit more, more about disease surveillance and pandemic preparedness, I'll try to also keep it fairly broad, focusing on health information system, because whichever way you want to look at it, you will realize all the data are important for a specific program. So why is it important to have reliable data for disease surveillance and pandemic preparedness? This is, I think, a self-speaking slide. What we often say is garbage in, garbage out. So if your input data are wrong, you get wrong results, and your actions are also always will be wrong. So what this really means is that good quality and timely data provide the strongest basis for disease surveillance, pandemic preparedness, and timely action. They are also important for monitoring the impact of the responses or of the interventions that we put in place. Critically important. So it's just not about seeing what is happening, but also, it's seeing which diseases are happening, but also seeing what is the impact of our interventions in the case we do have one, in the case of health emergencies. Perhaps this slide speaks a little better compared to the previous one. What this slide really shows is that when you have erroneous data, however well you analyze the data, you always get wrong results. And when you get wrong results, you get wrong conclusions. And when you get wrong conclusions, you arrive at wrong recommendations or you provide the wrong recommendations. And when you provide the wrong recommendations, any policy action plan that is based on those recommendations will often be wrong. So in other words, with less reliable data, you are driving, or we are driving the country into a ditch. So that is why it is very important that data should accurately describe the occurrence of an event and assure of an appropriate response. So where do the data for disease surveillance and pandemic preparedness come from? I want to start this slide by mentioning this. Disease surveillance is about the ability to detect the occurrence of disease outbreak in a timely manner. And the pandemic preparedness is about the ability to prepare the health systems and services for appropriate response. And this also includes all the work around health systems resilience. So therefore, when we are looking at the data for this, we want to look at data that will enable countries to detect, and also want to look at the data systems that will enable countries to strengthen the health systems and help make them more resilient than they are. So one key data source is the health facility data. So here, this is something that I think we're all familiar with. Under facility data, I've put 2 data systems. I believe there are many more data systems that are out there that we could talk about. The most important, perhaps, is the routine health information system. This is data which is collected when a person seeks care. It is the biggest source of data any country can have. But quite often, as you will agree with me, these data are beset with data quality problems. They are often incomplete, either because facilities are not reporting, or if they're reporting, they're not reporting all the indicator data, or because the private sector in many African countries that probably provide care to about half of the population are not reporting to the public health information system. Second important data source is facility assessments of service availability and readiness. There are specific examples here. WHO is supporting countries to implement the harmonized health facility assessment. Within this assessment, there are about 300 indicators focusing specifically on health emergencies. Even if those focus specifically on health emergencies, there are also other aspects that focus on the health system strength. So that's why facility assessment data are critically important. The second is, of course, is what we often refer to as health resources availability mapping, HRAMs. I'm sure you're all familiar with this. And the other facility assessments like the SPA service provision assessment, which is often supported by USAID, World Bank supports the work around service delivery indicators, and so on. So all these facility assessments are critically important for preparedness, pandemic preparedness, because these are the information that one will use to strengthen the health systems. The second important source of data for disease surveillance is civil registration and vital statistics. And particularly here, I want to highlight the point around routine mortality surveillance with medical certification of cause of death. In subsequent slides, we will see that actually this is an area where countries are struggling with. This routine surveillance is important. If countries are plotting patterns or trends of why people are dying, you can actually be able to detect that actually we are probably having any outbreak of a disease in a country. The third, which is perhaps the most familiar system that often people who deal with emergency talk about, is the system that talks about the disease surveillance. I like the point of Williams just mentioned. I think it's what is the discussion that you had today, that sometimes we tend to skew, we don't prioritize other data sources. We think that this data source, like I work in emergencies, so the only data system that's important for me is disease surveillance. So you ignore the other important data sources. You don't even invest in them. When COVID came, many countries actually struggled to get information on what the health system strength in their country was. They didn't have information about the facilities in the country, the services they were offering, the readiness they had to provide even those services. So those countries that had implemented facility assessments had, I think, an easy run because they had information. Where they didn't have facility assessment, they struggled. So that's why we say it is just not about disease surveillance that is important for emergencies. Other data systems must also be considered. And under this surveillance, of course, you do have the systems for assessing IHR core capacities and also predictive models that actually have now become so common. And some key, more recent emerging work around the precision public health. Another important source is the administrative records on human resources, financing, infrastructure, medicines, and other medical supplies. So this is one slide that looks at the current state. It's not, okay, the data are fairly old. Data were collected in 2018, but I can bet that really nothing much, I believe, has changed across the region regarding improvements in the availability, quality, and the timeliness of the data in the African countries. So this is a score assessment which was done by WHO. Actually, what we basically looked at here, where we looked at what information was available publicly and also those that countries hadn't shared. So we used that, we graded countries along a 5-point Likert scale from nascent capacity. Nascent means almost there's nothing going on to sustainable capacity. So the red on this graph, you can actually see that the reds are just too many, reds and oranges. Let's look at C, which stands for the count of births. In the African region, out of the 47 countries that I talked about, 30 had almost nothing going on. So it means all the work we're talking, all the things we're talking about, routine mortality surveillance for emergency preparedness cannot work in so many of the countries in the African region, in 30 countries. Even 13 countries have limited capacity. So this tells you that actually we still face substantial challenges as countries in the African region with data availability, quality, and use. The green is where you have sustainable capacity. You see the greens are very few. One country for count of births, one country for optimizing routine health information system, 9 for the reviews, and so on. So I will not spend a lot of time talking about this slide unless there be specific questions. I'm happy to come back to it. This is just further breakup of the various components of the score results. So again, if I wanted to highlight the bottom right, something on data-driven policy, because this is a policy dialogue event, and it's critically important that we know the extent to which data are used in the African region to drive policy. Indeed, policies are not only driven by evidence or data. Sometimes countries do have all their own aspirations with or without evidence, but that shouldn't mean that they can't be modified using available evidence. A country may have aspirations, or a president may have aspirations. Those aspirations need to be modified using available evidence. So if you see the bottom right graph, the data-driven policy, you see there are important gaps in the way countries in the African region are using information to inform decisions in the country. So this is something that needs to be actually urgently improved in the region. So this is a map that shows how well or how poorly the countries did across the world with regards to reporting information on COVID-19. And if you see here, most of African countries were in the red. So actually the capacity was low red in almost all the countries. Around 9 of the countries had no data. We only had 2 countries that had 3 countries in the region that were highlighted in blue: Algeria up there, South Africa, and then Mauritius further to the right. So African countries are facing substantial challenges with the data generation, data analysis, and use. So what are the issues? Of course, we have low data availability that I've talked about. Poor quality of data. Data often incomplete, a lot of inconsistencies, and data often not timely. And there are many reasons for this. I've put a few of them here. The biggest that we seem to have understood now is that there are important gaps in the systems and capacities for governance. There are leadership and coordination challenges at the country level with so many emerging data systems that are not coordinated enough, not aligned at all. Also importantly, as was shown by the previous graph, there seems to be limited appreciation of the importance of data in decision making. And therefore, where there is limited appreciation of the importance of data, you can be sure political will to improve systems will often be limited. Again, low investments in data systems. It is either low investment or fragmentation of investments. Actually, I'm increasingly believing strongly that there's a lot of investment going on in information systems, but the systems or the investment is fragmented. So small pieces here and there, there's no common investment framework in the African countries where we can say, let's put the resources together and have one common system that we're all focusing on and strengthening. Third is the work around the limited application or implementation of data standards. ICD-11 case definition, these are often not used. And of course, issues around inadequate human resources in terms of numbers, knowledge, and skills. Second broad area where the gaps are around the systems for data generation. Currently, most African countries are based in their data collection on paper systems. These are often cumbersome for health workers. They reduce the speed and accuracy of data collection and reporting. They are prone to errors, they can be damaged, and so on. And of course, the point that I found really making also the issue of failure to prioritize all data systems, focusing on, okay, this is an emergency. What is important for me is data on disease surveillance, not others. You don't look for other data sources. And yet you want to do proper data analysis, you need data from other sources because at some point you want to do triangulation, you want to try to do, you want to examine associations, what are the key factors associated with whatever you're observing. Importantly, capacity to analyze data is limited in the African region. And of course, the issue around there being no proper mechanisms to facilitate communication and use of health data. So this is my second last slide. What are the changes that are needed to improve data availability and the reliability in the African region? I just picked out the most strategic issues. One is African countries need a stronger governance for HIS with greatly enhanced leadership and ownership responsibility of Minister of Health in all data systems, be it civil registration and vital statistics, even which we know is mostly with Home Affairs, but the component of CLVS that concerns the Minister of Health, especially reporting of births, reporting of deaths, and certification of causes of death, that no other department, no other ministry can do it better than Minister of Health. Second thing that African countries need is more robust systems for data generation, storage, transmission, and importantly, taking advantage of innovations in information technology. Third is countries need to have stronger systems and capacity for data analysis, including data quality analysis. Particularly here, I'm talking about the routine health information system and analysis of ICD coded data. We are now moving the countries, we're supporting the countries to start implementing the International Classification of Disease, the 11th revision, which is also called ICD-11. So the capacity to analyze that data is critically important. Issues around inequality monitoring, using big data and the advanced predictive analytics to improve performance and deliver measurable impact will remain critically important in the Africa region. Capacity for this is low. We need to do a lot of work around this. The last part is enhanced data and information access and use. I think I've talked about this. I don't need to say more. But the point that will be made around using the data, even at the source of generation, is critically important. As the WHO, what we are focusing more on now is, can we strengthen the skills for data analysis at the facility level and at district level? Because we strongly believe that when data are used at the facility level, their quality and availability will always improve. Facilities should just not be data harvesters. They should be using the data available to improve the care of patients. First, data collection or data reporting should be a secondary event. So this is my last slide. It's an important note that we want to promote. One is that countries will have one common data approach. By one common data approach, we mean one fully harmonized or integrated data system within the framework for national health information system. We shouldn't be seeing parallel systems in the country which are fragmenting resources, increasing the burden of reporting on health workers. Second thing is we should have one government-led coordination mechanism with the participation of all stakeholders. Third is one overarching national strategic and M&E plan for the health sector. Program-specific plans and M&E can then align to the overall strategy and M&E framework. Importantly, one common investment framework. Resources, I believe, are enough for health information system at the country level. They are just, as I mentioned earlier, they're just fragmented. The only way to kill the fragmentation of resources and the data systems is to have a common investment framework. Last but not least, one monitoring and accountability platform, such as joint annual reviews for improved analysis and use of data. And lastly, one central repository of health data. Currently, we are supporting the countries to use DHIS2. In the 47 countries, 44 are now using DHIS2 as their data integration system. So we just have around 3 that actually are also willing to take on DHIS2. With DHIS2, I think we can be able to harmonize many of the systems and kill the fragmentation in the country. So I'll stop here. Sorry, I've taken longer than the time that was allocated to me. I hand over back to you, Vince. Thank you so much.
Yes, thank you very much, Benson. That was very much to the point and not so much over the time, in fact, compared to previous presentations that we have had here. But I'm going to go into but I think, are there any questions directly to follow up on this? Yes, there's a reaction, please. Yes, it's on. It was on, I think. Sorry. I think you have to press. No. Is it on? Sorry.
Thank you for the presentation. As I listened to your presentation, there were a lot of things that resonated with me from my experience in Liberia. I work at the Public Health Institute, where we are in charge of disease surveillance and emergency preparedness and response, amongst others. You broke down the various data collection systems, talking about the routine health facilities, surveillance data, mortality data, etc. What I want to know is what's your, I didn't get it clearly coming from the presentation, what's your recommendations as it relates? I know on your final slide, you did indicate that we should look at working towards having a central or one data collection system. But there are times where there are like agencies, specific agencies of government. For example, in some countries, you have a particular agency responsible for routine health information system data, whereas there may be another agency responsible for surveillance data. The first challenge that we have within our setting is that all of these data are collected at a peripheral level on paper-based forms. Okay, so firstly, what's your and because of that, we understand that it affects quality. You talk about garbage in, garbage out, and that's perhaps one of the primary reasons why we have poor quality data coming from most of low middle income countries. But in addition to most of these data being collected on paper-based form, we realize that surveillance data is not integrated with routine health information system data. So in Liberia, we have the integrated disease surveillance system, which you talk about, the IDSR, but IDSR data is also been collected through paper-based forms. We're gradually moving towards having an electronic IDSR system. The platform is being built, but there has been some discussions around ownership of the data and how could we possibly make that data interoperable with the routine DHIS system. So I just wanted to get his perspective on that because it's something that we are struggling with as a country. Thank you.
Okay. Thank you very much for that comment. I think there was another comment you wanted to, Reinhard, maybe we take your comment and then I ask Benson to respond.
Thank you, Benson. I would be a bit interested because clearly, just to follow up on this, there are these different data sources and typically they are separate from each other. whether you can hint our colleagues here to good example practices where such data are actually linked, so that we have the administrative data, maybe population survey data and surveillance data that some of my virology or microbiology colleagues collect data in the communities. And so whether there are any African good examples of combining these, let's say, at the district level. Thank you.
Perfect. Maybe I'll ask Benson first to respond to these and then I come back to you, okay?
Yeah, thank you so much, James. I think very important questions and comments. I think they are all related. The first is different agencies having different supporting different systems. In my presentation, I clearly mentioned that the systems will operate within a framework of the National Health Information System. Now, let us take a step back. And I want to mention this, that what we see as different systems is what we see at national level. If you go to healthcare facility, there's nothing called a different system, a different information system. Just take example of you in a hospital. There's no different system. Only that by the time people are now extracting data, that's when the fragmentation starts. The same health worker that's doing this, collecting data on disease surveillance, is the same health worker that's reporting on maternal deaths, is the same health worker that's reporting on TB. So the fragmentation, the talk of fragmentation, or we're different, starts at a higher level. National level and international level, we start seeing ourselves different. We start saying, oh, for me, I work on TB program, so I'm not concerned about disease surveillance for other areas. So this is clearly increasing the burden of reporting on the health workers, and it's something we can actually avoid. And I want to tie this with the point on interoperability and also the point on whether there are good examples where these systems can be integrated or can be combined. Indeed, each of these data systems is unique, and each one generates a different kind of data that is used for different purposes. But we do have systems where you can actually integrate the data sitting in one place. Let's just take DHS2, for instance. Within DHS2, we have data sitting for TB, for reproductive health, for family planning. They are all sitting in the same place. They are collected in different ways, but all sit in the same place. And DHS2 has capability, actually, to centralize data from all the different sources. I've worked with so many colleagues, so many partners. When the funds are available, they set up different systems. When funds are dry, they say, oh, can you help us and integrate this within whatever is happening? Now, the issue of interoperability is one that we are struggling with as well as WHO. Interoperability means you can keep your system provided you can link it to mine. And that's not what we are talking about when we want to talk about integration. When we talk about integration, we want everything to come to sit in one place, not via interoperability. Yes, there will be situations where interoperability is necessary, but it shouldn't be the norm that every time I set your system, I set my system, you set yours, provided the two are speaking to each other. That's the most important. That is expensive for countries like the region to maintain. It only works when the funds are there. But when the donors pull out, countries, that's why most of these systems tend to collapse. So we are looking at how can we have one integrated system that sustainably can be run by the countries with or without money. So this is really what is important. Yes, there are examples. The best example is DHS2. It can pull data from all these different systems into one place. The collection, some of the data can be done. Some of the data are collected through household surveys. That's a different source of data, but it can still be shipped back into DHS2 and operating within the national framework for health information system. I want to end with this. There is something we call the data architecture framework. The data architecture framework defines the actual data needs of a country. it defines the sources of the data, the mechanisms for collection of the data, how the data will be transmitted, how data will be stored. If countries have an architecture, a national data architecture, with all defining all these different components, that's the beginning for one harmonized health information system in the country. I hope I've been able to respond to those questions. Over to Williams.
I see there's a comment back to that question, and then I give it to you.
And your response, yes, you dealt with the different type of data, but specifically looking at the routine data. So the example that you gave with DHIS, with family planning data, malaria data, etc. Those are things that are working within our setting. But my concern was mainly looking at the IDSR data, because except, I mean, I may be wrong because I'm not a data person, but I'm not too sure that there is provision within DHIS for IDSR. So how do we harmonize that?
Thank you. Williams, will I respond to that?
Yes, please. You can respond.
Yeah. So perhaps the starting point is, yeah, I think I got your question. Your point is that there's no provision for IDSR data in DHIS2. But what is IDSR data? This data about diseases that have been defined for routine, I mean for surveillance. So that's that, or when somebody sees this, it must be notified. So IDSR data is simply because the decision was made to say this, when you see this condition, it must be notified. So the surveillance program is scouting for that. These are the same data collected in health facilities, and I can assure you there is a provision for all the data that's needed for integrating this surveillance in DHIS2. The provision is there. The only difference is how routinely should this data be reported and how they should be analyzed. That's the only difference, but the provision is there. And as I said, if we focus on strengthening the capacity at the facility level to analyze the trends and patterns, we will be able to, even we will not be struggling with, we need to have reporting of ideas. Facilities will be able to pick that on their own, and actually, just by looking at the trends of, say, malaria cases have now increased way and above what we have been seeing previously. So the provision is there in the DHIS2, and it can be integrated.
Okay, thank you. Sorry.
Because this is something that we are dealing with currently. If I got you right, are you suggesting that within the context of like a resource limited setting like Liberia, we may not need to have an electronic IDSR system and a DHIS system operating at the same time? Instead, more focus and attention should be placed on building the capacity of the health workers who collect the data at the peripheral level to feed into the DHIS system and build a platform for surveillance, priority surveillance diseases within the DHIS too. Is that what you're suggesting?
Okay, I'm not sure if that's what I'm suggesting, but let me say this. If you have IDSR data or system in a country, that's okay. If you want to use electronic system, that's okay. But the point I'm making is data should be collected once. Data should be reported once. Data can be analyzed so many times. So the system that we need to build in the country is that which allow data to be collected once and data to be reported once. As long as the same health worker is collecting data and reporting for IDSR and reporting the same data into DHIS2, that's duplication. That's something we should definitely try to avoid. I hope this answers.
Okay, maybe we need to follow up also with how other countries do it more specifically afterwards. And I think I take your question, and then Johanna, you wanted to say something, and I think then we really need to move to the next presentation.
Yeah, thank you, Mr. Benson, for the nice presentation. In your submission, you identified 3 areas where data collection, is a problem. The first one is the low data availability, and then data quality, and then the timeliness of reporting. I'm working on NTD, so I know exactly what you are talking about. When you go to the rural areas in the communities, this is a big problem. But I know some groups are also working to digitalize collection of data from communities. And I'm wondering how WHO can actually help these communities to digitalize collection of data so that this low data availability, etc., will be a thing of the past. So I just want to know how your outfit can help these communities to digitalize collection of data. Thank you.
Yeah, thank you so much. That's a very important and also perhaps one of the most difficult questions that we have struggled with. How do we improve, even if it's not digitalizing, how do we improve reporting of information from the community? This has always been a very big challenge. I'll give you an example. In mortality surveillance that I talked about previously, we have been trying to help countries to establish mortality surveillance systems at the community level. And this is often a challenge. So what we have decided then to do is, okay, look, for statistics on health, you don't need to have information on all deaths. You can base analysis on a sample of deaths. So what does that mean? Creating clusters for reporting or surveillance sites, so that instead of looking at data coming from all the communities, you're only picking data from a selected sites from the community. So that is one thing that we have now actually decided. I think that will help to reduce on the costs associated with reporting information from the communities. It is a big challenge. Currently, as WHO, we are actually not doing much work on supporting communities to digitalize the reporting of data at all. We are not, because we can't sustain it. But it is an approach that we're all struggling with. I think people in academia, this is actually something you can also help with. In a surveillance system, for mortality surveillance, what we've been telling people in academia is that, can we try to do research on the most sustainable or the most cost-effective approaches for improving, say, death and cause of death? What's the role of religious leaders? What's the role of the community leaders in this? So it is something that we need to do extensive research on. Thank you.
Thank you, Benson. I think we need to move on. Is it okay if I park your question for after the next presentation? Okay. So basically, I would then hand over. Thank you very much, Benson, again. I would then hand over to Mirawi. Are you there, Mirawi? Benson, you're staying on, right?
Yes, I can stay on. No problem.
Okay.
Thank you.
Okay, thank you. And Mirawi,
yes,
are you
I'm
there?
here.
Okay, very good. Then I would like to hand over directly to you and you can start your presentation. I think you should be able to share your slides if you have slides. And
Yes, can you see my screen?
yes. They are not yet in presentation mode, but we can see your slides already.
Is it in a presentation mode now?
Yeah, they are now in presentation mode and we see, yes, perfect.
All right, good afternoon, and apologies for missing this opportunity. Really, I tried to be there physically. Unfortunately, it was it was not possible anyway. So I think when I received this presentation as an agenda, what I picked, and when I saw that I'm coupled with my WHO colleague, I know that he will be deep diving into surveillance and the surveillance from the roots to the level of systems at national level. Now, I just want to bring to the next discussion into how we should really think of, as this is a regional consultation, I mean a regional dialogue, how we should really think of health information exchange policy and standards and for the digital health system. That's what I just want to brief you about here today. I think we have heard a lot about the challenges and the limitations in our ideas in all health information system for that matter. But despite that, we are still operating in an emergency response and preparing for and responding to health emergencies across different member states. What is main challenge now is when it comes to cross-border or health information exchange, that become really a challenge. So my talk is around this concept, how we as Africa CDC want to bridge this challenge and what the policy look like, the policy landscape look like in general. So just to give you some background, we are as Africa CDC are mandated to establish a continental framework for data sharing. And it is explicitly stated in our statute that life-saving information exchange is one of our duties and responsibilities. The other one is to improve data quality and develop interchangeable data elements that prepare the EU member states to respond to emergencies and timely disseminate critical life-saving information to member states. So this is really the background that we are operating. What has been done to enhance surveillance for better preparedness so far is in Africa CDC is we set up a regional integrated surveillance and laboratory network, which is it's in its own right a program, which is to maximize the available assets and information. Assets, both equipment, facility, workforce, all capacities in one country or in one region to be shared among member states and neighboring countries. That mechanism includes information, health information exchange, and sharing. The second one is enhanced surveillance capacity, including event-based surveillance, community surveillance, mortality surveillance, and a platform where member states are called in every week to exchange what's happening in their country so that the next country is aware of what's going on. This is an eco platform that we are currently operating with, so that at least with, if not for data, but at least information they can exchange. This is to build trust and confidence among member states, neighboring member states, so that they can be comfortable to share the next level of information, that is data, and maybe analysis, and also support each other in that regard. The other one is pathogen prioritization for better preparedness. That is what we put. This is like what are those frequently appearing health events in Africa that we need to really focus more on, including in diagnostics. I think that has been discussed in the earlier presentation when our RK colleagues were presenting, and also preparing for better preparing for those frequently appearing health events. The other one is genomic surveillance initiatives that we are really advocating and working for. This has been really at this peak in this COVID era, but we are really shifting towards other programs, especially also supporting disease surveillance for epidemic-prone diseases. The other piece that has been done so far to enhance is workforce development program, including training of epidemiologists, laboratory leadership for detection, as well as health informatics. We have these programs that really enhance surveillance and early detection. So despite this, EU member states have increasingly been implementing digital health system to improve health outcomes. I think we are moving towards digitization. I think, yeah, it is being completely different from the health information system like 5 years ago, 10 years ago, and we are moving towards digitization. However, most of these systems are use technologies that are functionally suboptimal and not interoperable. I think this has been frequently raised in our previous presenter. Interoperable digital health solutions provide immense opportunity. I think that has been well stated. This has also been touched in our previous presenter. What are the entry points to this? But what are those noticed challenges? I think that is what we want to see with this digital solution: lack of regulatory mechanism, competition and free market of digital solutions. This is in the sense of exchange. This was its own repercussion. Parallel systems with inability to interoperate, and wide diverse on capacity for digital solution implementation. I think this has been already mentioned. And the other one, most important piece is sensitivity with data and information. I think a lack of trust and digital solutions and opting towards more old methods, paper-based and so on. That is what we noticed when we really advocating for cross-border collaboration, coordination, information exchange, and difficulty in agreeing and signing of data sharing and information exchange. This is part of the sensitivity of the data and information. And of course, governance and leadership and empowerment of those people, especially districts, bordering districts. That is what we have noticed. So noticing these challenges, and there was no enabling policy and standards to guide health exchange, health information exchange across the continent as a critical gap. We've set up a task force and for AU health information exchange policy standards for use by member states. And it was set in 2020. And the purpose and the scope was to provide, a set policy standards and frameworks to guide EU member states in the implementation of HIE for digital health systems within the continent, and focus on electronic data exchange, security standards, and assist Africa CDC in defining and specifying a target system framework to guide its and EU member states long-term development and implementation of health systems. So in general, this is like regulation, standardization, and leadership, which includes harmonization of standards and policies, interoperability, exchange, and sharing, promotion on data visibility, access, and use. This is like, it needs really a huge advocacy and engagement and commitment from political leadership at all levels so that we have this life-saving information exchange across borders. Collaboration and partnership, I think that is one piece that we have been discussing earlier, providing incentives for health information exchange, training and mentorship, data analytics. I think this is one of substantive things for better preparedness, better data, and support development of infrastructure for HIEs and joint platform for sharing lessons and best practices. That is what we really envision moving forward. I think these are some of the processes that we have observed. Finally, I think I'm close to the end. We are currently HIE policy standard adaptation process. This has to go to the AU policy organs, as this is going to be AU document, AU member states document, and we move into capacity building. Then we go into advocacy and for data sharing agreements across member states. It's really, we have noted this the value of data sharing, data and material sharing agreement during this COVID era, especially with genomics surveillance that we have been supporting across borders with shipment of samples. And really, we need to move into interactive data analytics platform. I think one important piece, okay, when we are encouraging member states to exchange information, or even also to share with WHO or Africa CDC their information, I think one thing that we need to think about is what is in it for them anyway. When after sharing, they may have some visibility on the neighboring countries, but also they need to have this kind of incentive mechanism. It's not like financial, but also value-adding analytics that they can get out of may also really increase interactive data analytics platform need in member states so that data exchange will be easy. I think this, in a nutshell, what I want to bring you to your attention. I think while we are really focusing on surveillance, better data, and data capturing, I think now I am really taking you a little bit to the next exchange across borders. That is all. Thank you very much. Back to you, Chair.
Thank you so much, Maureen. I don't know if there are questions for him
or there are issues with. Yeah, Joanna had a question. Yeah. There's a question, because on this presentation, is there any question from? Yeah, okay.
Yeah, so I thought it was a very nice summary from the colleague from Africa CDC. Thank you very much. And then you mentioned you need this interactive platform for real-time analytics in a way to, but you had previously mentioned also the issue of trust between countries. So do you feel confident that Africa CDC, I mean, this is a challenge, right? So for both the WHO or for the regional CDCs. And do you think that given that challenge and where we are, that we can address this now, or do you have specific strategies? Basically, what do you think the likelihood of success of creating something like this in the very near future is? And yeah, I just wonder if you could comment on those challenges. Thank you.
Mary, I don't know if you have the question. Are you still with us? Hello? Please have to check, is Mary still on?
So may I come in, Chair?
Yes, you can respond.
Okay. May I come in, Chair?
Yes, you can.
Okay, thank you so much. Thank you. That is a really very important question that we really are struggling with. Okay, to get this buy-in across member states, neighboring countries, or across borders. One important piece that we may think of is to build the trust. I think what we are trying so far is to have that e-platform where they come every week and exchange what's happening in their country so that the neighboring country knows. This has created some level of confidence. But if we create a value-adding analytics platform where they can get advantage of, say, for example, where they share their data, if we add some other analytics or some models that can help them to see what is the potential risk, the dimension of that health event, and from their own data, then they will be very happy to come in and share and exchange this information. If there is we need really to think, be more creative, to have that such kind of an incentive mechanism where they can really be happy with to share their data. It is not an easy. It will be a really very difficult. It will be a really a very steepy way that we will be navigating, but that is of course no option. That we have to make it anyway, because we can't make sure that South Sudan will be safe when Ebola is in Uganda now, or Rwanda is safe when Ebola is still there neighboring. So when they get some incentive mechanism, analytics may be one of those things, they will share potentially. But building that trust, getting political commitment and engagement and ownership and leadership by the government themselves, it's the way forward. That is how we perceive this document. Thank you.
Yeah, thanks so much, Marawi. I think there's still another question here from John.
No, thank you very much. I think you have partially addressed what I was going to come on to, which is the issue of data safety and data protection. But you've mentioned this to some degree. I'm aware that the AU, even prior to the formation of the Africa CDC, had some data protection guidelines or document, I can't remember very well, which a number of member states had signed up to. I don't know whether this has been updated in the light of some of the things that you are desirous for, and also to what degree this is being integrated with the the WHO Afro data platforms that they have as well. Because I know, and perhaps Benson, you may want to comment more on this, that even within Afro, there are times when there is duplication of collection of data, different departments perhaps collecting the same thing. Even during COVID, this actually did happen, at least I can say on authority. And so I'm just wondering how what is being put in place to ensure that there is harmonization and non-duplication. I'm cognizant also that, I mean, different bodies have different mandates, and so may require different parts or aspects of different data. But if I understood well, looks like the desire is to have one big pot and everybody dips into that pot and takes what they want or what they need. And if you can, if you can just confirm that this is what the desire is, and if so, what is being done with the other regional bodies to move in this direction, and the necessary data protection mechanisms stemming from the AU data protection guidelines. Thank you.
Thank you. Thank you really very much for that important question. With regard to the digital policy of AU, that is what inspires this, the health exchange, the health information exchange policy and standard document that is still exists. I think that is what we base in. With regard to harmonization with other different actors, what we really look into this is the same concept that we want to really create in here. It applies for the hub as well as for WHO regional office and EMRO and Africa CDC. But what we are really looking into is to set those sets of standards and security. The main substantive thing is data security that we are advocating for. And the only that's what we are really working on, so that the people, I mean, the member states will be confident enough to share their data. It's not like we will have something that we control over, but we have access to and privilege to, but all administrative control will be governed and owned by the member states. And I think we will not really negotiate on the ownership and leadership of member states. With regard to WHO, I think currently we are closely working with, especially with Detect, Response, this initiative with the global health architecture. We are closely working with WHO regional offices, both Afro and EMRO. We are moving with this global health emergency architecture. And we are developing that concept of alignment and joint implementation of programs and initiatives. And I think we want to really maximize the resource utilization rather than duplication of effort and resources. So that is a spirit that we are working. This document has been, this concept has been really moved around region by region with regional bodies invited and member states for consultation and how we go about it to set the standards and data security issues. Thank you.
Yeah, thank you so much, Marawi. I think
I see Benson raising his hand.
Yeah, I don't know if there are any other questions. Benson? Benson?
Yes, please. I wanted to add my voice to what Marawi has explained around the issue of data sharing and how we can harmonize the systems between the partners and so on. I think I entirely agree with what Marawi has explained. And I want to go back to the point that I made earlier, that whatever we are referring to as fragmentation is our own making. It is high level. Down there, the data are coming from a common source. So all that we need as partners and so on is, one is the point that Marawi has already made. First of all, why should countries report data? what is in it for them? What are the incentive mechanisms that can be put in place to make them report data? Often countries have one key worry about data sharing. That is the issue around confidentiality. And quite often also the issue of confidentiality and data security tend to be confused. Data security is, I have my data, I don't want to be damaged, no one should add or remove anything from it. So you should have a system that ensures security of the data. Confidentiality is about having specific details about, say, a patient, that this data, if Benson had malaria, no one should know it was Benson who has data. But if we can clarify for the countries that once data have been aggregated, a lot of the data we need is aggregated data, it's not individual data. Confidentiality becomes important when we talk about individual data, but when we talk about aggregate data, the issue of confidentiality shouldn't actually arise. What will arise is issue around data security. So if you can allay those fears of data confidentiality and talk more about data security, that is, I think, one important aspect that will facilitate. Of course, the issue around why should they share data, we should answer that question for them always. Now, I mentioned earlier, data should be collected once and reported once. What that means is if we had a digital system where I'm a medical doctor, work in a hospital, all I do is I provide a care to the patient. I write a diagnosis and the collection of data is seamless. I don't even have to do anything about it. And data flows into a system at district level or at national level. And then at the level or regional level, we also have the same system which is linked to the global level, where data flows seamlessly. That is a system that we want. But to do that is not an easy thing. We can talk about it. It's easy. It looks easy on paper, but in the practice, there are practical challenges around issues of data sharing and so on. We have the Integrated African Health Observatory, which was basically built to address this. We have the data sometimes, even we can't get data to put into the observatory as WHO. So it is not something that can be done easily, but I think if we continue to have the conversations with the countries, why it is important to share data, allay the fears around data security, then we should be able to address some of these gaps. Thank you.
Thank you so much, Benson. I think it's better we hear from country perspective on this, if there are no questions, so that we just know what happened in the Anglophone countries and also the Francophone countries as regards data reliability, usage, prediction, and how it has been able to drive policies in these countries. I don't know if, okay, John?
I mean, I just wanted to, maybe reduce this to the lowest common denominator, literally, which is data on birth and death. Across the continent and in the sub-region, we know that even getting number of births and deaths in the countries per month is not available. During the COVID, many of us needed this baseline major denominator for work, and we could not get it. I used my contact at WHO right to the highest levels, only to have it declared that it does not exist. Even WHO does not have accurate enough, or actually does not have at all, the death data per year, even per month, per year for countries in Africa, except for maybe Egypt or a few others. I was completely surprised because my expectation was that at least mortality data would be available. And I know mortality data is fairly reliable. Of course, it may underrepresent, but death is, as I say, not a debatable state, and often is easy to ascertain, and so it's fairly reliable. This is such a critical denominator, and Bill, you know this. We're trying to have one of our PhDs do excess mortality, and well, I know what he's in for. He doesn't know, but he'll get around it. But this is just very basic, and I think once I have you, Merawi, and Benson online, maybe you can explain why even something as simple as births and deaths numbers, because you talked about just simple aggregated data. This is no secret. This is not national security data, but we don't even have that. So what are we really talking about?
Yeah, I think, yeah.
Sorry, I just said, I think because the question in fact relates also to how the data is collected. So I think we should first go to the countries to hear how this data, whether it is available and what the problems are in collecting this data. So that when we hear from the country perspectives, maybe starting with the Anglophone countries, or should we start with the Francophone?
I want to start with the Republic of Benin. Because it was just popping out to say something. So let's hear from Republic of Benin first. Yeah. I don't know, maybe you want to say something. Okay. Okay. Maybe Ghana, yes.
Okay, thank you. So yes, I'm happy Benson is on. I happen to partake in the earlier meeting we had some time ago on mortality surveillance, and I'm happy John talked about simple numbers, because it's not like a disease where you can make a diagnosis. If you have died, you have died. Shouldn't be a problem. Died in the community, died in a facility, you know, all die be die. But as part of this, we've been working on mortality surveillance. And we do know that people may die at home, in the community, and then also in the facility. But I think in terms of just counting the numbers of people who have died, it should be less difficult. Yeah. But then for the cause of death, that may be a bit more complicated. And I think I also took part in the first part of the training, looking at medical cause of death, and then also the team that is supposed to be formed. So I know that after that training, each country is expected to form a team, starting right from the community, from the facility, and then also to from vital statistics and then civil registration group. I know that in Ghana, we haven't formed that bigger team yet. Within the health sector, yes, it has, but we do know that statistical service and even some other academia, research institutes and all that, we need to form that whole surveillance team to have a better understanding, including the community, so that readily we can report. Because the whole idea is that everybody who dies within a country has to be buried. And then there's a process. So once you die, first within the institution, there must be a kind of certification that you have died. And typically it's somebody with the competency. And that's what then you have to write the medical certificate of cause of death. Then it translates into a death certificate. And then from there, you require a burial permit. In fact, I just lost my dad on Saturday. So I have gone through the process properly, not the one that I learned and what I tell people, but this one I have gone through. So yesterday I got the death certificate, and that is up to one point. They have also told me that if we really need the certificate, which is like the birth certificate, then we get a lawyer to write. So I think the process is there. The most important thing is that we need to really get the team together so that we can, but as far as the counting is concerned, you have to be buried. So it shouldn't have been, but if you don't involve the community well, then it's even difficult to get that figure as far as the counting is concerned. So I'll say that Africa CDC is already leading that process. And for my colleagues who are here from other countries, that process is there. Maybe if we do not know about it, when we are back in our countries, there were people who attended this, maybe from the National Public Health Institute, from the Directorate of Public Health, from Civil Registration, Vital Statistics, and some groups. And then I think when we mobilize ourselves within the country, it is easier to do the counting. Thank you very much.
Thank you so much. I don't know if there is any other information from any other country. Togo, Liberia. If it's similar, we just want to know so that at least we'll be able to have the perspective of death registration. We are not talking about birth registration, but at least death registration, so that we can have and monitor the mortality pattern over the years. Yeah, just press it. Good.
Yeah, I think from what I know on the surface is similar, because quite recently we did try to embark other project to look at SS mortality from COVID-19. I think that was a few months ago, along with the Bureau of Vital Statistics from the Ministry of Health. I mean, I'm not very familiar with the process, but I understand that there were similar challenges that were faced in terms of getting some of the information. So I think they were even able to proceed with that project under the WHO funding. So.
What about the autopsy? Or, I mean, capability to do autopsy and get results?
To ascertain the cause of death?
Yeah, to ascertain the cause of death.
I think it's basically reliant on the judgment of the clinician, and which at times sometimes we find questionable, especially for maternal deaths. Let me use maternal deaths for example, which is one of the public health conditions of importance that we review on a weekly basis. At least there is a mechanism now that we have in place to provide feedbacks to the facilities on some of the causes that we receive for maternal deaths, which I mean, ordinarily you wouldn't attribute as a cause of maternal death. If I mean, any reasonably sound clinician wouldn't just come up with such cause for maternal death without maybe doing like further investigations. So I've seen that from time to time with maternal deaths, and the causes are usually questionable, even though there is a system in place for all of those deaths to be reviewed before they are and verified. But it is often the case that you don't have the right persons around the table all the time. And I think the right group of people include either the attending physician or the midwife, the medical director of the hospital, the county health officer, and other senior persons to be around the table. But it's almost always the case that you don't have those people around the table. So usually it's either the attending physician or even a midwife who handle those cases, come up with those kinds of diagnoses. So it's always a challenge for my team from the surveillance end, where have to call on a weekly basis, reach out to the facilities and do additional investigations before we can finally ascertain or report the cause of maternal death.
Yeah, actually, this will take me to another aspect in terms of the quality of the person ascertaining the death, and this vary from one country to the other on the laboratory capacity, and often diagnoses are just based on syndromic or just visual look, and that is why you said some of those diagnoses can be questionable, and at the end of the day, that also translates to reliability of data that will now inform the kind of decision that has been taken over time. I think before I go on that, maybe I should just hear one or two from other countries. And yes, that's Ivory Coast, right? Cote d'Ivoire. Thank you.
For Cote d'Ivoire, in terms of data collecting, we have for epidemiological surveillance routine, we have for the other diseases, and especially for COVID-19, we created another platform for collecting data from COVID-19. So I don't know if it were the better way to do that, but as we have to collect information on people individually, so that makes I would say the information very sensitive. So we didn't put all this information in the routine surveillance. Yeah, so I don't know what do you think about that, but
yeah, I think the issue you're talking about is the sensitivity and the fact that our cultural practices in relation to death and all that might be a very big factor in in the release of data sometimes. And this is an issue that I know will be of a great importance in Africa because of the peculiarities of some cultural influences. Yeah. I don't know what happened in other countries, maybe Burkina Faso. Yes. You can speak French, which will be translated. Yeah.
Ok, merci. Il faut dire qu'au niveau du Burkina, au niveau des sources, c'est à peu près ce qui a été cité. Nous avons les données de routine avec le système de DHIS2 dont nous avons parlé. Et beaucoup de pays ont parlé de ça. Nous avons également les données d'enquête, les enquêtes qui sont réalisées, surtout avec l'Institut national de la statistique et de la démographie. Là, des enquêtes qui se font soit tous les 5 ans ou bien tous les 10 ans. Donc, ils nous fournissent un certain nombre de réalités. Nous avons également, dans le cadre de la surveillance épidémiologique, le Centre des opérations et de réponse aux urgences sanitaires, le CORUS, qui est mis en place et qui permet de développer un système de surveillance, j'allais dire cas par cas, depuis les différents villages. Donc là, les données remontent directement et régulièrement et centralisées jusqu'au niveau central pour permettre de voir un peu quelle est la situation d'ensemble, où s'est produit tel ou tel événement et à partir de là, prendre les décisions qui s'imposent. Bon, concernant les décès maternels, il faut dire que c'est essentiellement les audits de décès maternels qui sont réalisés. Au niveau donc des communautés, nous avons les agents de santé à base communautaire qui doivent notifier tout cas de décès et également au niveau des formations sanitaires. Et à partir de là, il y a tout un processus qui est développé au niveau district pour réaliser les audits de décès et essayer de voir quelle est la cause des décès. Et au fur et à mesure qu'on monte au niveau des hôpitaux, là, c'est beaucoup plus, comme il a dit, c'est beaucoup plus scientifiquement mené et on peut avoir des causes de décès assez spécifiques. Donc, quand on prend l'ensemble de la surveillance, il faut dire que nous avons des surveillances qui sont quand même assez parcellaires. Et un des gros défis, c'est de permettre, j'allais dire, une coordination sur le plan national. Et à cet effet, la plateforme One Health, qui est en train de se développer et se mettre en place, en tout cas petit à petit, est à encourager à ce niveau. Et nous avons également d'autres plateformes qui existent, plateformes dans le domaine de la nutrition également, etc. Et donc, il nécessite vraiment qu'il y ait une coordination pour tirer la substance d'ensemble sur le plan national et puis essayer d'orienter les différentes décisions. Donc, je ne sais pas s'il y a quelque chose à ajouter. Oui, pour la COVID-19, en fait, il me pose la question concernant la COVID-19. C'est ça que je dis, le centre des opérations et de réponse aux urgences sanitaires. Là, on avait un système mis en place avec différents niveaux où les populations peuvent appeler et s'informer, dire tout ce qu'il y a. Des équipes d'intervention qui vont sur le terrain pour mener les différentes activités de sensibilisation, de désinfection des domiciles, ainsi de suite, jusqu'au niveau des centres de prise en charge. Centre de prise en charge, un centre de prise en charge national qui était, si je prends au niveau de la capitale, un centre universitaire où les cas étaient pris en charge. Donc, oui, c'est ce que je dis. La base de données COVID, avec le centre des opérations, on a une base de données COVID.
Just put it there and press 2 you should be able to hear precisely what you're saying. And there are quite a lot of information, yes? There are quite a lot of information we can derive from that. I don't know if you don't hear French, you can use this and you'll be able to get it well. The translation is quite nice and you'll be able to get what it's saying. Yeah. Yes. I know there's someone who wants to speak also. Yes, you can. Just press it. That's good.
Yeah, thank you. I just wanted to add a few words on what my colleagues just said. Yes, on top of the data sources that we have in Burkina Faso, I would like to emphasize that we also have the same problem as far as civil registration and battery statistic is concerned.
Okay.
Because this is really not at the optimum, because first of a health attendance rate that is very weak. It's roughly that 1/3 of people in need are really attending the health facilities. And we will have documentation of deaths that occur at the health facility level, but not at the community level where like 60% of deaths occurred there. We were able to run a study in our HDSS, Health and Demographic Surveillance System, that shows that 95% of dead people, they don't have any documentation. The few that have documentation did it because of financial incentive, because if it's a person working with the government or working in a place where there is a succession, they need the documentation, something back the administration to find documentation for that. Beside in the rural area, it's really like 2% of death where we were able to find documentation, meaning that it will be really difficult to use this as a data source in a place like Burkina Faso. Thank you.
Thank you so much. And this actually takes me to quite a lot of, okay, from Republic of Benin. Yes, you are ready now.
Involved in Benin, that's the reason why I cannot really say something about data collection in Benin. But what I can say is that I'm a modeler, so I use data, let's say, to analyze trend and so on. And it's very easy to see that most of the data are biased, The most reliable data are the admission to hospital intensive care units and death. But even with death, comorbidity is also something challenging. So in this case, is it possible, for example, to say that the guy died due to COVID-19 or due to kidney disease or other disease? So this is also challenging, but these data, of course, are more reliable than, new cases and so on. Thank you.
Okay. Yes, from Togo.
Thank you. Just to add, the data sources are almost the same as we were just saying, but I just wanted to add some points. The first is on mortality data. We are facing the same difficulty in Togo. And one of the reasons we discussed with forensic medicine departments is that the process of declaring or registering the death is not standardized and it's not well known of the population. So as Prof was saying just right now, people used to go through the process only where there is maybe financial outcome behind it. So it's one of the challenges. So I know they are actually working on put in place a standard procedure for the deaf declaration, and maybe it will lead to better data. But the other phase of the problem is what will happen in rural area. This one is also a challenge. So concerning COVID pandemic, we also used or produced a lot of data based on survey data. And one thing that we acknowledged was that since, and we was discussing this today, since the founders vary a lot, and the institution conducting the surveys are also different institutions. Sometimes we lack a way to put in all the data together, maybe to have a more general specific point of view, that we should maybe think about a way of, in such emergency situation, having maybe national platforms to put together all those data going in the same direction for big data analysis or such things, for better decision, better analysis and then better decision. Thank you.
Thank you. I have, okay, from Liberia again.
Yeah, thank you. Regarding the sources of data, I think most of the emphasis have been placed on public acquired data. One of the key challenges I think we face is the data from the private sector or academia. And I would just like to give an example. And like my colleague has just said, the more you accumulate the data from all sectors and be able to compile those data, I think they inform better decisions and they help to guide programs and policy. I'd like to give Liberia as an example. That's where I've done almost all my work. Say, for example, we did studies on the Ebola vaccine. Those vaccines, both from Merck and Janssen, both of those vaccines has been approved by the key regulators, that is the US FDA and the EMA. But the data that were provided from Liberia that aided the approval of those vaccines are not in the public data set by the government Ministry of Health. They are not there. Studies were done in regards to community response during outbreak situation. We have a lot of anthropological data. Those data are held in academia at the university level. Those data are not within the public health system. And those are data that inform pandemic preparedness and also outbreak response. So I think all I'm trying to say is basically that part of the agenda from this meeting or discussion or dialogue should be able to provide recommendation to countries within the West African basin to be able to find suitable mechanism to integrate data from academia and the public and the private sector to help make better country level decisions in regards to outbreak response. Thank you.
Yeah. Okay, just briefly, then I want to round up this session so that we can go for coffee and we start another session. So I'll just give you a few minutes.
Okay. No, I was just going to really add to the point that is just being made about the fact that it's not just public data, but there's data sitting in other places. And in my own experience during the pandemic, we ran a survey just to assess whether people would take the vaccine, etc., you name it. At that point, there was no, as far as we were aware, any such large-scale survey that had been done. to inform the willingness to accept the vaccine.
Okay.
Subsequently, we then made it sort of available as part of the publishing process. You have to disclose the data, etc. But it would have been nice if that data plus those that others had done were all in one place, and then you can then run some AI algorithms, you name it, so just really supporting the point that really has been made here. Yeah.
Thank you so much. I think I should go to Marawi and Benson. Just give them a minute to just wrap up the session so that we can go for coffee. Benson, are you still there? Marawi?
Yes, I'm here.
Yes,
just a word from you to round up the session.
Yeah, thank you. Do I come after Malawi or I come now?
No, you can come now.
Okay. Yeah, thank you so much. I think I've really enjoyed these discussions. And one important point that seems to be emerging is the urgent need to bring together data that are sitting in different places. I think this is very important for the countries in the African region. And one way actually of doing that is, as I mentioned earlier, is to have an integrated system. And to build that integrated system, we need to start with a properly articulated data architecture framework. What are the data needs? Who is collecting the data? How can data be transmitted, stored, and all the policies around that? I think that is a very, very important point, which has come out very clearly in this meeting. The discussion around the challenges associated with the death and the cause of death reporting is actually is real, as I explained in my earlier presentation. Out of the 47 countries in the African region, 30 have almost no system for proper reporting of deaths and the causes of deaths, as well as births. That, at least with the births, countries are doing fairly well. Now, there was a specific question to WHO about how is it that the expectation that WHO will have data on deaths and the causes of deaths. And the point I want to make here is that the data WHO has is coming from countries. So if countries don't have data, we also don't have the data. So therefore, a lot of effort should be put to support countries to improve the reporting of deaths and causes of deaths. We believe strongly that it is possible to achieve 100% death notification. In the death notification, we're talking about minimal data set, saying so and so from this place has died without cause of death information. And that is important, just to know by counting how many people have died. But public health decisions are not based on how many people have died, but they're based on what are people dying of. So that then brings in the issue of the need for proper certification of cause of death, either through the verbal autopsy system, which is done at the community level, or medical certification of cause of death that can be done in healthcare facilities. Now, I want to end by saying this. When we talk about disease surveillance, we should have a system that does surveillance for all diseases, because any disease has the potential to cause a pandemic or to become a pandemic. Previously, we paid little attention to NCDs. Now NCDs are becoming an important aspect because we need to have surveillance system for that. That's why building a system, you cannot say I'm going to have a system for disease surveillance separated from any other routine information system, because you practically have to look at any disease that has the potential to cause an outbreak, not just those that have been defined. So I want to end here and really thank you once again for inviting me to participate in this discussion. I just wish I was there because I can see the level of engagement is really rich. I hope next time I'll have the opportunity to come. I will definitely make sure that I participate in it. Thank you so much.
Yeah, Benson, thank you so very much. We would have also loved to have you here. I'm very sure next time you will be here with us. A last word from Marawi. Marawi, are you still on?
Yes, I'm here. Thank you, Chair. Thank you very much for the rich conversation here. I think what I want to really conclude my point here is, I think we have been discussing about the challenges about what is better data, where is it, and how can we make it really better, and who has that data, and how can we make a really integrated, harmonized data, and finally exchange with among stakeholders, including neighboring countries and other major stakeholders. I think one piece that is also raised here is about mortality. I think we have noted that in Africa, CDC has a major challenge across member states. In different countries, we have mortality record and the civil registration somewhere else, and we don't have access to as a health sector. But in some member states, we have some access. And some countries start to have, like including Ethiopia here, one data center when they can access data from different sources, including academia, civil registration, and other institutions. I think that is a lesson that we can also take from. Maybe we're moving forward, we may need to come up with a modality where we have one data center, national data center, where we can get access from different data sources that are relevant to public health. Maybe down the line, climate data, and so on and so on. So maybe just to put one point, that mortality surveillance is a unit in Africa CDC, and we will be very happy to support if there is such an initiative in your countries and member states in the region in West Africa. We have now a program in South Africa, Uganda, and it's really, we noted really of great value of this mortality surveillance during this Ebola outbreak. When you see some of those things that were retrospectively analyzed, that the Ebola was taken back to early around August or so. It's really very, very important to have such a system where we can have visibility of a number of diseases, in addition to the cause of diseases in member states. Finally, in the era of this digital systems, I think what we need to really advocate for is on the create and build is confidence among member states, and the security, data security, and interoperability, so that we have one point of truth. I mean, so that we can have a real public health action that can save lives and their livelihood. Thank you very much. Back to you, Chair. I really appreciate for inviting me into this dialogue. Thank you very much.
Thank you, Mayor. I think we should just round up. I want to round up by just asking the following questions, and we should just think about it and work on it from our country. Do we really have, is data available? Is the data that are available, are they well coordinated or integrated? Would they ever be useful for sound predictions? And will it be useful to drive policy? What is the quality of this data? What is the relationship of the infrastructures and human capacity that we have to deliver on this data? And how have we used this data to drive policy in Africa? I think with this, it will give us time to think through and see what we have done in Africa and what we intend to do, and how to push to make sure that the data we have generated so far that are hidden and some that are not even found yet will be useful to drive policy in Africa. I want to say thank you for you listening and the interaction. I think it's time to take just a little coffee, relax, and so that we can come back for another session. Thank you so much. Yeah.
Yeah. So, I mean, the question is now, how long is our coffee break? And I think in view of how far we are behind the program and that we want to have dinner at some point also later, we shouldn't make it too long. So maybe we start back at 4:20. So 15 minutes coffee break. We had, yeah, I think that should be enough, right? Yeah, okay, good. Even to think about the questions that you just made and maybe to discuss these further. Okay, thank you. So at 4:20, we continue.
So please, the four speakers, keep to the 10 minutes in order to have really question and answers, and also a debate on what the WHO hub, what G-WAC and other internationally active agencies could contribute to building up the capacities for the general topic now of this third panel, and this is better analysis. Yeah, so this second part of the 3 steps in the slogan of the WHO hub and also of our conference, how to analyze the data in a way that is really helpful for decision making, will be at the core of what our 4 speakers talk about. And the first one I would like shortly to introduce is Professor Vitali Belik, junior professor at the Freie Universität Berlin in the Institute for Veterinary Epidemiology and Biometrics. You see in his case, as in the others also, how interdisciplinary in nature health, especially public health and global health, are. So the speakers come from different faculties and they have even more different educational backgrounds. So Vitali Belik has a PhD from the University of Göttingen in theoretical physics, postdoctoral experience at the Massachusetts Institute of Technology, and now in his current function, he is focusing on many aspects of digitalization of artificial intelligence in health-related issues, like, for example, deep learning for animal emotions and behavior recognition, digital pathology, natural language processing, digital epidemiology, mobility research, biostatistics, also sequencing of RNA, and microbiome data analysis. And today, I think he will speak on a project he's currently running together with our G-WAC members, Professor Rainer Busse and Christian Drosten. So he will introduce some ways of modeling in COVID-19, especially as far as I know. So is he already online? Yes, so the floor is yours, Vitali.
Yes, thank you very much. Do you hear me?
Yes.
Oh, great, okay. Thank you very much for the nice introduction, and it's a pleasure for me to participate in this event. So I will shortly, so this is a very short talk, and I will introduce you to some methods we would like to use in modeling possible epidemics in Ghana. So in particular, we discuss some computational epidemiological approaches, especially taking into account the human mobility being a major driving factor of epidemic spread. I would also shortly introduce some so-called infodemiological approaches to assess changes in human behavior during epidemics. So digital epidemiology tries to assess, to use the data, which a very huge amount of data which are available now in the context of some epidemiological spread. And one of the example and one of the important parts of the digital epidemiology is the epidemiological modeling, computer modeling of epidemic spread. And here's an example of artificial disease spreading in the United States. So the simulation started in Los Angeles and it spread in this very irregular wave pattern through the whole country. So the blue areas corresponds to the areas with a low number of infected. The areas in red color corresponds to the a lot of infected individuals, and so on. And so we used for this simulation a realistic mobility patterns of individuals in the United States. So to produce such simulations, there are, for example, an approach which is called metapopulation is frequently used. Metapopulation approach means that we have distinct populations like cities or some areas or even countries, and we distinguish between so-called local dynamics, so infectious dynamics in a population, and in the interaction of this one affected population with other populations via, for example, travel of humans in this case, as we have a human host of this disease. And this is usually done using so-called compartmental model, where we assume for like local dynamics that we have, for example, susceptible, infected, and recovered, and the corresponding dynamics. And usually the assumption is that the population is well mixed. That means that everybody could theoretically meet and contact everyone and infect everyone. However, we could also do further refinements of this model, taking heterogeneity of contacts into account, where we explicitly take into account the contact of physical contact networks. So, of course, the mobility is very important in this context. And alternatively, or additionally to this approach, we could also use agent-based model, where we really implement hosts as agents able to infect each other. As an example of such an approach, I presented you one study where we investigated approximately 200 hospitals in the state of Lower Saxony in Germany. The hospitals are presented by circles here, and patients were transferred between these hospitals, and it's shown in these arrows. The bright arrow means a lot of transfers of patients between them. And of course, such kind of system is very important for the spread of, for example, nosocomial diseases happening in hospitals, such as, for example, antibiotic resistance. And I was mentioning human mobility as a key factor in spread of diseases geographically. And to assess this, nowadays we have a nice tool, mobile phones. And here just trajectories of 2 individuals over like 7 days are shown in this case from Paris. So it is a pleasure to participate in this project funded by Berlin University Alliance, where we're trying to implement a epidemiological model for Ghana. And it's based on the assessing the mobility patterns of individuals in Ghana. So we hope that we get access to anonymized and probably aggregated mobility profiles. And this will help us to construct the dynamical mobility network, which we could plug into our epidemiological model. And of course, the result of our simulation will be compared with the experimental empirical part of this project, where the seroprevalence and incidence will be recorded at different locations in Ghana. So this is how the mobility network could look like. Also note that this is just a model, so it's not a real data, but this is how it could look like. And we will use the approaches I already mentioned, metapopulation approach, including stochasticity aspect, for example, using agent-based model. Well, of course, we will take into account the characteristics of population, such as age distribution and further socio-economical factors. And we could even build on the already existing model for Germany. Our model is just a tool for decision-making, we will implement relevant measures, for example, quarantining, or we could variate vaccine efficacies. And of course, this model could be useful not only in the context of COVID-19 epidemic, but also for some other diseases, such for example as flu. And the model will be recalibrated and updated, of course, based on the empirical data. And it could be extended to include other modes of transportation, for example, air transportation. One of the challenges in this project would be to assess the human behavior, because humans could change their behavior as in response to like measures, containment measures. And to assess behavior is very important. So here it's just shown the results of the surveys done in Germany, where different colors corresponds to the contacts happening in different settings. And you see how the number of contacts is changing with time. So you could imagine that it's very costly attempt to assess this behavior using surveys. We would like to use, for example, internet media analysis in this context to try to assess human behavior. So what you can see here, for example, is the distribution of the topics in news media. So here, for example, the magenta shows you the topic corresponding to sports and school cancellations in Poland, as one colleague comes from Poland. You can see also here the sentiment analysis in Twitter, so that text loaded with particular emotions and how it changes during time. And you can also analyze, we can also analyze the networks of retweet, what we see here. Yeah, so different nodes corresponds to users and connections between two retweets. Yeah, so our hope is also to use this method in our project. One can even assess the co-occurrences and occurrences of side effects of vaccines if you find the proper data on the internet on this, yeah, which could even be better than the clinical studies. Like the resolution, it could be better than openly published clinical studies. So on this, I would just end. So thank you very much for your attention. That's my contact details. And I hope that somebody from you could help us to get access to the data we need for our models. Thank you very much.
Yeah, thank you, especially also for keeping time that strictly, which allows us time for perhaps one or two questions of understanding. We will have an extensive debate on what use we would like to make with what kind of support of these new technical possibilities in modeling. But any questions to Vitaly Bilik on understanding? No, okay, then yeah, I'm looking forward to taking up these models he presented in the later discussion. So the next one will be one of our present speakers. Yeah, it's Professor Romain Glele-Kakai. I hope I pronounce it somehow understandably. So one of our Francophone guests here, but participants, but he will speak in English. I first encountered him actually when we were encouraged in our application phase for the G-WAC, for the DID Center, to get in touch with Humboldt fellows and applicants for an Alexander von Humboldt hub. And he was one of those who expressed interest in collaborating with later G-WAC. And so I'm quite glad that he's here today. And that's the first step in this collaboration that we are really looking forward to. So he is a professor of biostatistics, actually, and as he told me, the director of the only English master course in Francophone Togo, which really emphasizes, of course, the importance and the international need for this kind of programs. Yeah, so we are really looking forward to your presentation.
The IT load his presentation, please.
So while we are waiting, perhaps an additional remark on the interdisciplinarity. He's in the forestry faculty. So again, another faculty contributing its expertise on modeling to the area of health, or should be a switch? Is Dr. Meyer-Rath already?
Yeah.
Yes, she is. Okay. Yeah, then let's switch the program slightly in order to allow the presentation to be prepared. Or is it prepared? Romain, is it prepared? Okay, yeah, now we follow the program as foreseen. This mic.
Okay, so I will be given a presentation on COVID-19 modeling in West Africa. I'm the coordinator of the Humboldt Research Hub on socio-ecological and spatial temporal modeling of COVID-19 in Africa. Okay. Help me. Okay. So, since the emergence of SARS-CoV-2 in the world, there have been so many publications on the pandemic, including, of course, the modern aspects. And what have we done in terms of COVID-19 modeling in West Africa? So I want to present what my team is composed of master student, PhD student, and postdoc students. So the first step is to consider West Africa as a whole, and we use compartmental model to estimate the production of Africa. So, sensitivity analysis reduction in the transmission due to implemented, and we also estimated the reduction of the control of the reduction in the transmission to control measures. And at the second step, of the disease of the pandemic in each of the 16 countries in West Africa, by estimating the production number, the two peak for the first wave, the peak of the reported cases, and also the final epidemic sizes and other key epidemiological parameters. What we notice is that this some weaknesses lead to identifiability issues in the estimation of parameters. So we develop a statistical model using the growth model of China, 1974. So we adapt the Turner model on the COVID-19 data. So we use it is at the beginning of the pandemic, and also West Africa does not have sufficient data for the application. So we use Italian data to test the model,
And we noticed that the model worked well with COVID-19 data. Estimate some key epidemiological parameters. So using from this model, we now we combine this model, statistical model, with compartmental model, considering an exponential growth at the beginning of the epidemic when non-control measures have not yet applied, and of course the logistic trend when control measures have been applied. So using this hybrid model, it was possible, for example, to estimate the delay between the introduction of the first infectious individual in West Africa and the detection of the the detection of the first case in the region. And we also let's say, estimate other parameters. What is important here is that with such a model, it's possible to have an analytical expression of each compartment in the compartmental model. So that's what we did, and we develop, of course, many modeling tools, and the main question is if these modeling techniques, let's say, give reliable estimation, reliable prediction on COVID-19 dynamics. So we analyze the performance of different modeling techniques used in the literature to predict COVID-19 dynamic. And we also discuss, so we use here artificial intelligence based modeling technique, Bayesian technique. We consider also compartmental modeling, hybrid modeling, statistical modeling, and non-linear modeling. And we also discuss here data quality, of course, which affects prediction COVID-19 dynamic. Now, the Benin Academy of Science organized a seminar where I was invited to present the different lesson modeling that have been done. And here I focus on the impact of the vaccination program in West Africa using a distributed model. And I show that the vaccination, of course, have a significant impact on the dynamic of the disease, but the only data type of data that we use are the daily, of course, new cases and death. And these data are, let's say, somewhat biased because due to reporting bias and so on, we have not, we do not have access to reliable data like admission to hospital, intensive care units. What we are doing now is to develop a model, a joint model, taking into account opinion of individual, of people, and disease dynamic. So we consider opinion and attitudes of people toward prophylactic control measures and vaccine, and let's say analyze how this opinion directly or indirectly impact the disease dynamic. So that's what we are doing now. The model is quite ready, and now we are trying to apply to COVID-19 data and see this model can, of course, be applied not only to COVID-19, but epidemic. So that's what we are doing right now. I would like to thank the German Federal Foreign Office and also Alexander von Humboldt Foundation. Thank you very much.
Thanks very much to Romain, of course, from Benin and not Togo, as I said, but I read the name of the president, the first president of Togo, Sylvanus Olympio, at the room there, and I was thinking of Togo instead of Benin, sorry. Yeah, so thanks also for keeping the time that strictly. Again, if you have questions of understanding, you can direct them to Romain now. Yeah, there's one, please.
Okay, thank you very much, Prof. Quite interesting watching that, just that I also have a bit of the math background, so I can appreciate that. And I wanted to get your thoughts briefly between the statistical models and the compartmental models. Which ones did you find more useful in terms of the ability to actually predict the direction of the disease, especially given the fact that in the early days, many of the compartmental models, the parameters just were not reliable for many African countries. So even like the death statistics, etc., became very tricky to use proxy data from some other place that didn't rely. But we found in some of the work that we did that actually a simple growth model was largely very predictive of the spread in the early days of the pandemic. But I just wanted to get your thoughts on that.
Okay, thank you very much. It's a very interesting question, comparison between compartmental model and statistical model. As you just said, compartmental model use some parameters that are not reliable. Why? Because most of these parameters are computed using data from other regions in the world. So it's of course better to use growth model. The issue here is that with statistical model, it's not possible to analyze different aspects of the dynamic of a disease. You know, with statistical model, you can estimate different parameters, but how let's say different compartment in the population interact is difficult for a statistical model. So that's the reason why we develop a hybrid modeling technique using advantage of both both techniques, and also try to let's say try to minimize the weaknesses of the model. But of course, the hybrid model is more, let's say, complex compared to the other model. So depending on your objective, you can use either a compartmental model or statistical model. That's what I can say. Thank you.
Thank you, Prof. I just wanted to come down to the normal utilization of what you presented.
So I just ended a study where we have the modelers, the decision makers, and the boundaries of organization that are in between the modelers and the decision makers. So it appears that these are the two, the modelers and the decision makers, those who are generating data mainly are sitting each in its corner and working differently. And in the other hand, the decision makers, they say they don't have the capacity to understand this model. So I have two questions for you. First, what was the collaboration between your work and those who are generating the data on the ground to build your model? And the second one is how can you really simplify this model to make it understandable by the decision makers so that they got to use it for the decision? Thank you.
Thank you for your question. It's really a difficult question. You know, what we did in Benin is to organize a workshop. So all these results have been presented in a workshop. And let's say a package of the result and the main conclusion sent to the Ministry of Health. And we are now collaborating, I mean, the ministry and my laboratory. So EDCTP funded the program to train people coming from the ministry in biostatistics so that they can understand, let's say, result from modeling studies. So that's what we are doing now. We are collaborating. What I can say, we will continue the collaboration and see how we can really work together so that they can use results of the modeling technique for decision making. So all the result and the main conclusion have been sent to them. Now the question is if they really use this result in the management of COVID-19. So I don't know so far. Thank you.
Yeah, thank you. So I think the last question should be posed to all the participants, to all the speakers, because that's the crucial question, issue, yeah, how to make it understandable for policymakers. And I think will be central also to our debate. There's one
we come to that tomorrow, better decisions.
Yes, probably, but the analytics must prepare this decisions, and therefore this understandability, I think, is crucial. Yeah, Michael. Yes, I know. Yeah.
Okay, Prof. Thanks for the presentation. Just to follow up on the previous question on the compartmental models and what they seek to do. So during the COVID, I'm a lab-based person, so I generate a lot of the data and also read papers of some of the modelers who say that we are able to predict that in a month's time, we are going to have reached the peak, and therefore we have to prepare like this or that. But the results that get to them are always lagging. You know, sometimes because of delay in release of results, you may have a lag time of a week or two before they get the data. So most of the time, what they tell us is not realistic. When they are telling us that we'll reach the peak, you don't reach the peak. And when they feel you will not get to the peak, that is when you are at the peak. So just to find out from you, during this phase of the pandemic, with these models that you predicted, how were they closely related to reality? This is something I just want to find out from what you've done.
Okay, I did not well follow the question, but what I can say is that in the last publication I showed, so on the reliability of prediction on COVID-19, we analyze all these aspects using modeling technique published in the literature. You know, there is a minimum sample, a minimum number of observations that allow to well estimated the peak of an epidemic. So at the first stage of an epidemic, if you decide to estimate a peak, of course, your estimation will be biased. You need to, let's say, have enough data to be able to estimate the peak. So this study is ongoing right now. What is the minimum number of observations to well estimate the peak of an epidemic? Is what my colleague just said. Compartmental modeling use some parameters, for example, computed using Chinese data, because at the beginning the virus come from China, so there were many studies computed key parameters, and in compartmental modeling, you are obliged to use some parameters because it's not possible to estimate all the parameters. There are many. So you fit some parameters and you find them in the literature and you estimated the remaining parameters. So when you use parameters computed on data from China, from Italy, and so on, of course, this introduces bias in the estimation. So there are many things that can, let's say, impact prediction of the peak. Now, using statistical modeling like growth model will help to really well estimate the peak. Now, the problem is with a statistical model, you cannot do sensitivity analysis. That is very important for decision making. So compartmental model have some weaknesses and some strength. Statistical model too. So it's important to know, depending on what is your objective, to know what modeling technique you'll be using for your studies. So that's what I can say.
Sorry, I can't allow any further questions now because we really run out of time. Yeah, we were really afraid when preparing this session that it could become too technical at some points. We are glad that our speakers really tried to explain it also to a non-mathematical audience. But yeah, well, at the end, we will take all these concerns up in the discussion. So our next speaker, third speaker, comes originally from the medical field. Gesine Meyer-Rath is a medical doctor with a MD PhD from the Berlin universities, and later on she earned herself also a PhD from in health economics from the London School of Tropical Medicine and Hygiene. And so she has a broad training. She is active at several universities, as far as I know. Here now she is a representative of the University of Witwatersrand, but she is also, or has been an associate professor at the Department of Global Health at Boston University in the US. And in South Africa, she was able to transfer the experience she gained in her research, in her policy recommendations on HIV, including a budget impact model on for ART, into this new urgent field of also health economics and modeling, the COVID pandemic. And we are really looking forward to the insight into these studies. So
thank you very much. Thanks a lot for the introduction. So I really like the set of questions we had just now, because this is very much what I'll try to focus in my talk about. I'll also talk about models in mathematics for those of us who like that kind of stuff. But my main focus is really about how to make disease modeling count in decision making, for which I think the South African experience might be a useful case study.
Currently still see the presenter mode. We currently still see the presenter mode of the slides. Maybe you could switch the view to duplication.
Can you see
like we see your slides, but it's basically the presenter mode where we would see your notes.
I just watched it.
Oh, now it's fine. Now it's perfect.
Okay, perfect. All right. Okay. So so I'm presenting this on behalf of the South African COVID-19 Modeling Consortium. I myself, as mentioned, am at the University of the Witwatersrand in South Africa, but I also have an affiliation with Boston University. The South African COVID-19 Modeling Consortium was established very early on by request of the National Department of Health in South Africa. And basically what they did is they pulled together all the country's known infectious disease modelers, and that includes Professor Cecil Seelal from University of Cape Town, who is one of the country's main malaria modelers, Juliet Pulliam from Stellenbosch University, who was an Ebola modeler, all of us health economists from HERO at the University of the Witwatersrand, who normally spend our days modeling TB and HIV. And put us in contact with Harry Moultrie from the National Institute for Communicable Diseases, who convened the consortium, but was also responsible for feeding data to us. So that was a perfect setup. We then spent the next 2 years doing this. So this is our 4 COVID case waves that we've had so far. This ends about a year ago with the beginning of the Omicron wave, which of course went a lot higher. Just to give you an idea of these little lines here, and I don't expect anyone to read the detail, but just to get an idea, these are the outputs of the modeling consortium, which were always a lot more interesting on the uptick of a wave. And then, interest died a little bit down while we were watching cases fall. And then, of course, with the uptick of a next wave, the interest is there again. And I just want to point out, as previous speakers have said, it's exceptionally easy to model the first peak of an infectious disease, especially to getting the exponential growth right. It's really, really hard to then talk about the timing and the reasons for additional waves thereafter. And that is exactly why we were asked to kind of, whenever cases started going up, to answer questions about how bad is this variant, what will it mean in particular to our inpatient capacity. So we used one very central model, the National COVID-19 EPI model. That's exactly what it was called because that was its purpose, the NCM. We were not the only modelers. There were a number of other groups, but we were the only ones who kept going at this for 2 years while maintaining whatever other work we were paid to do as well. We started with a simple SEA IR compartmental model that was stochastically fitted, but otherwise a fairly simple dynamic model, which had a fairly complex from the beginning hospital pathway. This is our first version. 6 versions later, it looked like this. We had 4 different variants and a number of different vaccination strategies that all had to be incorporated into then predicting the additional waves, especially this was made for predicting wave 4. So I would be completely remiss if I pretended that South Africa is anywhere like other places in low and middle income countries when it comes to data. And I know this is not the topic now, but I just want to kind of give an idea of what we were sitting on, basically a goldmine of data. South Africa has an existing surveillance system for respiratory disease generally, including in hospitals, which was within record time in March and basically done by May 2020, expanded to include all hospitals, which gave us exceptionally good data on the number of hospital-based or admitted COVID cases as well as deaths. We also have a national health laboratory system with huge PCR capacity, which basically meant that which we already have to run our fairly substantial HIV treatment program and do viral loads there. And all of that was then turned into SARS-CoV-2 PCR testing. We have an existing vital registry system that turns out excess mortality estimates every month, but now, of course, was exceptionally important during this time and gave us very good model data inputs in terms of not so much just the hospital deaths, but the vast majority of deaths that happened outside of the hospitals and often in the absence of an actual COVID diagnosis. We also, just to hark back to what was discussed earlier, we had excellent mobility data from cell phone networks. Some of the data came from Google. What's important here is that we found it really hard to equate mobility to context. Just because two people with cell phones have been in the same place doesn't mean that they were close enough to kind of basically exchange SARS-CoV-2. We also, and that is perhaps the biggest data mine that we had excellent SARS-CoV-2 seroprevalence surveys. Altogether 12 surveys. The colorful dots are kind of how many data points we had. This is by province. Most provinces or all provinces were covered, though not all of them over time. That was mostly in the bigger provinces like Gauteng and the Western Cape and KwaZulu-Natal. But it allowed us to have time series data. And in blue here is basically what our model then estimated to be the combined exposure, so antibodies from both vaccination and exposure over a cumulative 4 waves. And as you can see, in almost all places, we end up with 100% exposure or immunity rather, both through vaccination. We have around about 50% vaccination coverage now, and in particular previous infections. So we are right now sitting pretty in South Africa. We also believe, and this is as a complete aside, that this is representative of what has happened in large parts of Africa in terms of cumulative exposure. And all we need to know now is how long these antibodies will keep us safe collectively. We had some survey data on basically restrictions and measures and people's adherence thereof, but we didn't find that useful at all for our modeling, and I'm happy to discuss that. Basically, we produced a number of outputs, and every single one of them was custom made for a policy partner and for planning. We started with geospatial tracking of cases. That was nice to kind of put out in the public at first. We worked very closely with a number of ministerial advisory committees on policy and went on to advise cabinet and the National COVID Control Council chaired by the president. For the National Department of Health, we calculated everything, and that includes, these are projections, I think, for the first wave, in terms of number of beds needed, oxygen requirements, staff, drug quantities, field hospitals, and then very much breaking our hearts at the height of the first wave, the placement of mortuary containers and graveyard spaces. We advised the National Health Laboratory Service on the number of PCR tests required, but also how to optimize testing algorithms in the shortage, despite all of our PCR capacity to deal with the shortage of testing capacity, in particular staff who could do that. We talked to the Treasury about the budgets needed, and that's one of our budget models for the COVID-19 response overall, and then the vaccination programs, and were directly responsible for 2 additional adjustment budgets with quite substantial amounts of money being committed to COVID. We did a lot of work directly available to the public. So this is resurgence monitoring, where again, across all the provinces, we were monitoring when exactly an increase in cases would meet our criteria of another wave. And in the end, it was up to us, the modeling consortium, to basically declare waves in each of the provinces, which was perhaps overstating our role a little bit. We also looked at scenario modeling. So again, for the next wave, a couple of scenarios for how bad, especially inpatient use would be. and then did short-term forecasting to catch up on that. So basically 2 weeks ahead of time to warn facilities ahead of time. I'll speed up a bit. When you start working with infectious disease modelers, one of the nice things about that is that you also have all the capacity on board to look at the new variants. And you might be aware that South Africa was responsible for 2 new variants, the Beta and the Omicron variant. This is at the very much at the beginning of the Omicron wave. We were able to look at the data in this case in terms of reinfection. So that's what we would have expected to see at new cases for people who had already had COVID. And this is what we saw. And from that came the first estimates of the immune evasion properties of Omicron that led to, basically, this was broadcast around the world. There's a science paper that Judith Pulliam led and contributed to the decision worldwide to pursue Omicron-specific boosters, which are now being rolled out worldwide. I'll skip through the economic analyses. This is what I'm mostly responsible for, but basically over time we had to answer questions ranging from very much at the beginning, what will COVID cost us? So exactly how much budget do we need to reserve just even for the gloves and masks, etc. Budget impact analyses that we did a number of over time. To which drugs and vaccines should we invest in? Should South Africa join COVAX? It did. Not much came through it. And how many vaccine doses do we in fact need now that we've made the decision to go ahead with vaccination? So for those, we did economic analyses for decision making, but then also for quantification. So saying exactly how many doses of which vaccine would be needed in which place in South Africa over time. And then lastly, that was actually the first question that we were asked, not even before the budgets. When should we hit stop on the economy? So when should we start with large-scale lockdowns? Where is the balance between lives and livelihoods? That is unfortunately a question that took us until about 12 months ago to be able to answer, so much too late for decision-making. But at that stage, we were ready because we finally had a model available to estimate the macroeconomic impact of COVID as well. I'll skip through this. This is our macroeconomic model that basically links the EPI model, the NCEM, with an generalized equilibrium model that was already existing, and additional literature on shocks. It's called Tecanello, which is a PD4 balance, and it's trying to do exactly that. What was important here is that firstly, we knew that we had already lost basically 5 years of economic growth by the end of 2021. The question was exactly 12 months ago, as we were looking at the Omicron wave, seeing what we knew about both vaccination at that stage and previous exposure, but also being not entirely certain how bad Omicron would be. The question to us was, do we lock down again? And so we put out a couple of scenarios to show that yes, there will most likely be another decrease in GDP growth, but it can be recouped. And those, even though we said there could be, so if we do stronger restrictions now, we could lose another 9 billion in 2022 as a result. But we warned from the beginning that the largest impact would be from international travel bans, which was, of course, outside of our sphere of influence and came to pass. So while the South African government took our advice at that stage and kept restrictions to an absolute minimum, safe in the knowledge that both previous exposure and vaccination would keep us safe from large amounts of deaths and severe disease, we had no sway with the UK government that introduced a new travel ban and yes, wiped off, like we had said, quite a lot of our GDP in the process. So I'll focus the last 3 slides on our lessons learned in terms of analytics relationships, which is really important, and then also what this means for pandemic preparedness going forward. We learned that agility and adaptability is key to remaining useful. So we kept switching between types of models. We at the beginning, as one would, started with an agent-based model, then very quickly realized that we needed to model for all the provinces and too much detail. So we switched back to a compartmental model. We also realized that we needed to have this emphasis on uncertainty. And there were many times when we were pushed to say something, for example, about the exact value of mask wearing, or whether or not to close which types of schools, where we said, we cannot tell you. If we told you, we'd be lying, just because we knew that the uncertainty was too high. The uncertainty, of course, became because we came from not knowing exactly the biological factors, and that understanding growing in real time. Just like speakers before, we did use Chinese data at the beginning, and that was the only data and was pretty perfect at the time. We didn't have local data, despite South Africa being a gold mine for data, but for many things, we still had to basically work with experts and expert opinion. And we didn't have, like any other COVID modeling group in the world, a perfect understanding of the population's behavior. We also had to adapt not to what should be there, but what is. And the most painful example of that is that in our first round of outputs regarding ICU beds, we kind of projected a need that would basically have gone way beyond ICU beds required. So we adjusted that for a use scenario, which basically was limited to the number of beds available. And we also then in our 2-week projections showed clearly when and whether in this next projected wave that danger zone of inpatient capacity overwhelm would be reached. In terms of relationship, really importantly, we cannot emphasize enough that it's a danger to underestimate the value of relationships. So to establish right from the beginning a good pipeline with the national government and Ministry of Health, but also with the district planners at the lowest levels and implementers. One of our main outputs were these maps of districts where we said, these places are going from control to where you need to start alerting especially the inpatient facilities, to where you need to respond, basically shifting resources, shifting beds, shifting staff, and switching on the oxygen again. So a lot of this was to do with using industrial oxygen for medical oxygen and vice versa. And at some stage then also starting to dig more graves again. So those things are important. We put out the metrics, but someone else has to take us seriously enough, believe in the value of our modeling, and actually then ready the resources on the ground. We also, of course, worked very closely with the data authorities and with scientific experts. There were still, until the end, a number of questions that we could not glean from the literature as much as we wanted, or from our own data. And public awareness is equally fundamental to build trust. We did a lot we made all our reports available. We did a lot of press work. We had a very active social media feed, which all, of course, had to happen on top of the analytical work. My last slide is really summarizing this, and I know I'm going a little bit over time. Apologies for that. In terms of what does it mean for pandemic preparedness? So basically, all of us now have 2 options, especially there where we have build some analytical capacity during COVID. And I'm really, really, really pleased to see that that is happening in other countries as well. So either we wait for the next threat and reconstitute this analytical activity then, or we continue and build on our current strength. The question here is that it pivots on whether or not we will recognize the next threat early enough to reconstitute in time, but also to ready the models at that stage for early decision-making, especially vis-a-vis the macroeconomic impact. So do we lock down now, or do we wait a little bit more? For this, we need to sustain a core competency for modeling big impact diseases, not just, and I completely agree, infectious diseases, also non-communicable diseases. We have to capitalize on the trust that has been established wherever that has, we've managed to do that, and the proven record of translating and analysis for policymakers and the public. And we have to use our experience to build capacity now, so that low and middle income countries can be represented in global decision-making from the start. We as a group were represented at the WHO SAGE modeling groups, etc., but we were forever the only ones. And I don't think that can continue into the future. So I just want to finish, of course, as modelers, what we do is, instead of thinking that these cases are going down here, they're under control, and oh my goodness, it's exponential, as politicians might do, we know right from the beginning it's actually exponential. Thank you very much.
Yeah, thank you. so I deviated from my timekeeping because in the end, 2 questions were promised to be addressed, and that's health economics and lessons learned dealing with uncertainties, which is something, and the other talks had not that much emphasized so far, and which I think are important for our debate, of course. Yeah, so John, are we going to have the next speaker now, or would you allow certain questions? No, next speaker. Okay, then we will have the last speaker, who will be introduced by John Amuasi, and afterwards we will have our discussion.
So thank you very much. It is my pleasure to introduce the next speaker, Dr. Theophilus Champong. He is an economist and he likes to refer to himself as a data enthusiast. He is someone who is both academic but also at the policy level, engaged in advising governments, particularly in Africa, on big ticket issues related to oil and gas, but also to health. And during the pandemic, we worked together on a couple of things, including modeling the pandemic in Ghana, and that paper has been published in PLOS. The title is this: The Data Tell the True Story. And we used the data from the early part of the pandemic to do some interesting modeling. Our conclusion of that paper is more like the data, the true story. It tells you a story, but there's enough evidence to show that it is not the true story, which is, points to this drink deep or taste not statement that either you have data that is good and representative and tells the correct story, or otherwise you're just saying something with what you have, which doesn't really mean what the reality is, at least for the entire picture. Anyway, Theo is here. He came all the way from Glasgow, Scotland, arrived just this afternoon. He's a popular feature in the Ghanaian media. He's not very popular with the government, but interestingly, they keep calling him all the time for advice because he has the facts and the figures and the knowledge. So Theophilus, you're very welcome.
Okay. I think my work is actually done by the last speaker from South Africa, who spoke to a number of the issues on the economic front and then the data aspect of things, but also in the discussions that we've had, that the data and the decision making that you derive out of this is only as good as it gets. In a sense, it's garbage in, garbage out in many instances, and we saw it in several jurisdictions, but particularly in the case of Ghana, where John talks about the paper that we did, and as you can see in the case of South Africa, which I might probably say is a bit of an exception in the sense that you see all the key data points that you need to really make an optimal evidence-based decision in a sense available. But in many of the other countries, it was quite challenging. I do recall during our discussion about the need to do several prevalence surveys across the board just to see where the reproduction was going and things like that. And it just wasn't, really available. But I will quickly steal a little bit of your time just to talk about the decision-making aspects, but more around how we can actually link some of the that we've collected to some of the national identification drive that we've seen across the board, and particularly in the case of Ghana, there's a big national ID exercise going on. In Ghana 2 weeks ago, I managed to get my Ghana card, which took me about an hour to process. But there's so much that one can actually do with that Ghana card, particularly from health sort of systems and a data sort of systems point of view. And I want to, I think, is that the slide? Green. Okay. Okay. So yeah, that's really what I kind of want to discuss. And just a few examples from how this is done in Botswana, in the UK, in India, and then some ideas of how this can be done in the case of Ghana in that respect. I mean, the point really is that several countries and jurisdictions collect different data for different purposes. But mostly, you do from the point of view, the data categories in two strands. You can have a standard system like you've got in the blue bar there, or you can integrate your existing databases using your foundational identification system. So, for example, your national ID card. If you look at it again from that foundational point of view, some advantages if you decided to actually the systems rather than just do the individual siloed approach. The first one, which we've discussed in the other sessions, really is the idea of increased efficiency. So here, from an economic point of view, we're talking about economies of scale, and the idea that you don't want to duplicate databases and systems, but also, and this was discussed again this afternoon, the idea that you can actually have opportunities for interoperability. You can still have different databases, but depending on the unique ID or identifiers that you have, you can cross-reference these databases depending on the needs. It's about this idea of mutual reinforcement, and here the idea again that as you build these databases and systems, and as they talk to each other, it gets better, and the quality of the decision making also improves subsequently. So there's actually an interesting study done by the World Bank in 2018, which highlights a number of these points that are just reference, quite interesting and useful, and I would recommend it for extra reading. But quickly, when we talk about a couple of the case studies, and we'll talk about Ghana, Botswana is quite interesting from 2 points of view. So for them, they have 2 foundational databases. You've got the national ID, just like in Ghana we do have, but we also have this birth and death registration system in the country. Actually done is to link the birth and death database with the national ID, they call it the online system, so to then bring this data to be able to use that as a source of reference, for example, to access different public services, including when you go to the hospital, getting access to your social benefits and things like that. What they actually do is that when you're given a unique number, and that unique number subsequently, I think at age 15, just like you got, or we're trying to do in Ghana, that becomes your national ID number. So you just have one number that literally more or less stays with you the rest of your life. And interestingly, there was a case study where we then use this national ID number from these 2 systems to drive one of the flagship ART programs in the country. So you can see an attempt to use 2 seemingly different databases, but link it to different health interventions that is being given or delivered in the country at different points in time. And this is Botswana. This is not even an OECD or European country. So it can be done. In the sentence similar, so when child was born, she was given a number. It's called a CHI number, so community health number, and again, it's just a combination of her birth date and 4 digits at the back, and that number more or less stays with her again from birth to death. She's able to stay within the system, except that in the UK, you can use it to access any other public services besides going to see a GP. So in Botswana, you can use your number to access different things. In the UK, that number is more or less tied to just your GP, but you can put that number together with your what we call national insurance number, begin to see all sorts of possibilities open up. Quickly, India is also trying to do something similar. And in India's case, what they're trying to really do is to digitize the medical records. And there's this program that but it's based on the idea that you have a unique 14-digit number that allows you to be able to access different services. And I think that if we look at government, there's a possibility to actually do this with the national ID card. So like many other countries, you have a multiplicity of cards, a multiplicity of documents that we use for identification. If you go to the hospital, people can the hospital give you on their database. The birth certificate. In the past, our parents used to go to the hospital with these yellow cards that literally had all of your history on it. Recently, we have the health insurance card, and then there's the government card. I think there's a possibility here to link a number of these things, but the unique thing really is that with the government card, the ID number you have will become the unique identifier. We can then bring that back from some of these existing databases. But then if I go to a hospital at either the district or region or the tertiary institutions, records for those that already have that Ghana card can be more or less integrated. And then the possibilities begin to emerge about disease modeling, the population, and issues. But I think for those that are under 50, because in Ghana's case, you cannot get a Ghana card unless you're 15 years. So if you're under 15, then just like what Botswana does, and just like what the UK does, you could actually be issued a unique ID. Subsequently, when you turn 15, that ID becomes your national ID. But then it's all then part of this one big database, and you can then see the possibilities from another sort of point of view. The previous speakers spoke about the big data and sort of the analytics related issues, but I kind of like to wrap up from sit as a expert, but I do dabble in it, and I see the potential for actually not just using the data for the cellulars, but more importantly, actually drive efficiency savings within the system and ensure that the allocation decisions that we're making, those resources the most are the ones that are provided. So when it comes to things like universal health coverage, I think we really have a massive potential here to use that national or the Ghana ID card to drive that universal healthcare coverage. And of course, we can do with the data that population level studies and related things. But importantly, for me, you know, see data sitting, we need to get them to talk together. Countries, we collect a lot of demographic data, surveys, population and housing census, multiple indicator surveys, you name it. But we're not harnessing these data points, in my view, enough. And this is where I think we can do a lot more on. And the last point really is, depending on all of this, are issues about the interfaces that we need to build to be able to have that interoperability, and then also the issues about data security, data governance, and the institutional issues that are needed to drive that. For institutions, and this point has been said, really are operating in silos, and to force them to start working and thinking together. More in the last 2 years working on interdisciplinary projects than probably I would have done if I was just working as an economist in a small corner somewhere. So thank you very much, and it's been a great pleasure to be here.
Yeah, thanks also from my side. I think that was really putting another side also to this whole debate on what kind of data could we use, by what kind of analysis, for what purposes. So may I just ask the two speakers that are present, Theophilus and Romain, to sit here with me for the final discussion. Yeah, so there are many aspects that have been addressed, some of them of a rather technical nature, some of them really of high political importance. And yeah, coming from Germany as the motherland of data protection, of course, especially the last talk, yeah, it's raised a lot of questions, and probably many countries in the world will be far ahead of us in the use of health data for research, like Botswana, for example. Yeah, so first question. No, you had one already to the last talk, and then Ben, I keep you in mind, so please start.
Thank you. Just a comment and then a question. What the speaker from South Africa said made a lot of sense for me, because in our experience in Togo, we were asked by the Ministry of Health to do the modeling exercise about the COVID-19 pandemic back in March 2020, where the first cases were beginning to appear in Togo. But we didn't have the human resources or technical ability to do such analysis. Then we put together a group of experts, Togolese experts, but in foreign countries, in Europe, in USA, that did that exercise. But what we came out with as recommendation is that it was not made to be a one-time exercise. They should try to put a team in place with competencies that will, I mean, it's supposed to be a regular work of modeling in order to adjust the decision by and by. And I think that's what the team was doing in South Africa. My only question was that, how was the work founded? Is it just for my interest? Because in Togo, that work that we did, it was kind of a free work. People that we contacted and put together were not paid by the government for that work. But just as for information, how is the work founded or financed in South Africa? Thank you.
That's a question to Gesina Meyer-Rath. Are you listening?
Yeah, thanks a lot. That's an excellent question. Essentially what happened, I think at the beginning of COVID, no one had COVID specific funding, right? And the same was true for us. So we basically used our existing grants that we had for malaria, HIV, TB, Ebola to basically fund, and we discussed it with the funders, and they were all, in agreement to fund our work on modeling COVID. And then while we did the work, we also applied continuously, in fact, for COVID-specific modeling funding We were not successful until I think about a year ago. So very much at the last, in the last 6 months, I think of our 2.5 year modeling experience, we were actually funded by WHO and Gates in turn to model the vaccination specific aspects, which then brought back a little bit of money. But at the beginning, it was really us repurposing other soft funding that we had for us to be able to do that. I mean, it also meant, doing that work on top of the stuff we were funded to do. So I think all of us went into these kind of 20-hour work days and so on. So we did that for basically 2 straight years, doing the main work and the COVID work on top. But I think that's exactly the point why we need a tranche of pandemic preparedness and modeling funding to keep these activities alive in between pandemics.
Certainly also the experience from Germany that by the pandemic, it became visible how much work is voluntary work in these fields. Committees of really highly national importance working in a sometimes not very professional way because they lack the resources, for example, for assistance, not for additional payment of these people who are usually paid as professors or so on, but really also for doing the hard job of literature reviews and all this. Yeah, so Ben was the next question.
Thank you. My question is to the first speaker on the South African experience. How do we use this wonderful South African experience to help nations that might not have enough data or might not have capacity to analyze their data to help to inform decisions? Number 2, what should we put in place, especially to train the younger ones that will take over from us over time to increase their capacity in the use of data, analyzing data to drive policies? Number 3, how do we use these economic data to inform policy that will help in economic recovery, especially during this post-COVID era?
3 excellent questions, if I may start. So I think what's really important in thinking through capacity building is not so much to focus on what we have now, but where we need to be in 5 and 10 and 15 and possibly 50 years time. And that's, of course, where the answer to the second question comes in, future capacity. I think it's really important to kind of use the momentum we have generated in this moment to last us way beyond the next couple of years, to kind of use hubs, initiatives like the Pandemic Preparedness Hub and the increased funding for that to make the case that we need more data and analytics in health decision-making generally, whether during the time of a pandemic or a new health threat or in between. And I think it's working off experiences like South Africa, where we have data to show that the modeling and the way that we were able to say where the next when the next wave would hit, in which order it would go through the provinces, and then to shift inpatient resources accordingly, that actually made the case. And that's very unusual for modeling actually saving lives, and you normally don't get to do that really. So I think being very strategic about writing up our experiences, bringing that to the attention of funders, and seeing what we can build in terms of a very efficient and kind of nimble health analytics workforce and data stream capacity is really the key, while also building capacity. And that's something that we've now committed to, that whatever grants we have, we will add additional people and degrees. I don't know how everyone else is doing with this, but we find it really hard to get scholarships for degrees, but that's of course what you need. So to just be a bit more intentional and also kind of pushing the envelope on existing funding or you know, the grants that we're submitting, to add these budgets in, and basically starting from, you know, grants that are purposefully for perhaps one disease, but to kind of build capacity while you're doing it, build institutions rather than just, you know, adding a couple of people to your own team. Basically to reserve this capacity and to keep building it out into the future. I think that's, so I think it's both big steps towards a future where this will be possible, and where being an infectious disease modeler or analyst or data analyst, data scientist, AI specialist actually becomes an interesting career for Africans in Africa. I think that is really what we need to start almost visualizing and working towards.
Yeah, thanks. So the focus of our discussion actually was rather intended to be how RKI, the new WHO hub, or also G-WAC academia in generally, could really support this move towards better analytics. And yeah, therefore I would invite now contributions, your views on this. Perhaps you would start already.
Yeah, I think you're absolutely right. I mean, at the end of the day, it's all about the money, and funding is key to drive all of these things. To do a very good survey, even in Ghana, I was privileged to have done around one national survey of about 2,400 people, 95% confidence interval, and that across the length and breadth of the country cost $30,000 just for a small survey like that. Question is, how many of our universities or even government agencies really have that money to be able to provide those things? So I think the collaboration really is key here. And the new institutions that are being set up, the new partnerships, G-WACs, all help to actually plug a bit of that void or a bit of the gap. But ultimately, in my view, we need to get our governments to actually fund some of these things ourselves. In many countries, the R&D spending in Africa is actually less than a percentage of GDP. In some places, it's like 0.05 and things like that. And clearly, when we're talking about pandemic preparedness and better decision-making, the evidence or the story from COVID, in my view, really is that we need to be able to fund our own development and fund the things that are important. If we can find money to buy V8 vehicles and drive around, then surely we can find money to actually support R&D on the continent.
I see another question.
Yeah, thank you very much. Theo, I wondered your thoughts on these observations. Even though you were able to get your national identification card within a week, you would find out that when you go to communities, it still takes a lot of time. Now, we would want to build data right from the community levels, but in our current strategy of issuing ID cards to everyone above 15, you still would have challenges getting it at the community level. It means that getting enrolled into the national identification system for us to monitor your health indices, if we can, we're going to have problems. These are some of the problems that we have in terms of building local capacities at the community levels for the communities to generate data, because they would be able to find within that enclave who is staying where and who is coming out with diseases, so that we can be able to map up diseases profile, spatial distributions based on the national identification card. And we are even lucky currently that we've linked it to our telephone systems, and therefore even reaching out to people with very weak digital addresses to their physical household would be very good. Over.
Yeah, a quick response to that. I think the solution really is in effective decentralization. You can see that whether it's healthcare or it's education or any other public service, everything is concentrated in many of our countries in the capital, and the decision making at the core or from the base is very, very weak. It's part a concentration of a power issue. And I think the solution really is if we can effectively decentralize and push the decision making to the centers and the places where it's most needed, then the district director of health or district director of education or whoever can actually make that decision and ensure that the data generation process is scientific enough. Because sometimes you get the data coming through all right, but until you start doing the analysis, you realize that most times there are challenges with how the data was collected and processed at the base. And so we need to go back to the base, which is decentralization.
I don't want to, because I'm not sure about the timing of this. I think a general question, I was very interested in the discussion around the modeling and what countries thought. And so the hub is very interested in supporting analytical capacity. I think there's also a clear realization that you cannot have the type of modeling that was described in South Africa everywhere. In Germany, for example, we also haven't had very developed modeling. So I was very interested in the presentation from Benin, not just for the modeling you did, but almost like in what you have managed to create there, right? And one question is, for example, for me is do we need to recreate that everywhere? I'm not sure we do. Maybe it's enough if one country in West Africa develops a bit of a concentration. This has you described the degree that you found it to get a critical mass, because you do need a bit of a critical mass. So I would be interested to hear from you a bit about how you managed to build that. And the second from all of you, and we don't have to do it today, but one of the questions is maybe a regional thing, something that where someone like the WHO can support the creation of that, or can sort of have support centers of excellence emerging, including by bringing them together, having this convening function, right? Because I'm not sure we can replicate even what you've built in Benin in each of the countries that's here in the room. So I'm curious to hear, and also congratulations on your success.
Okay, thank you very much for your observation. So in my case, you know, I did my PhD in Belgium. And at this moment, we do not have biostatistician in Benin. And my idea is to really build capacity in data analysis in Benin once I finish my PhD. And I did my postdoc with the Alexander von Humboldt support in Germany, where at the University of Freiburg, where I found a very strong unit in data analysis. And this, of course, let's say, gave me idea to try to set up. But, you know, to set up such a program in Benin, you need to become full professor. Because if you are not full professor, it will be very difficult. So I wait until I become full professor to, let's say, contact colleagues in the region. Because in this program, master and PhD program, some of colleagues, even from Togo, from Cameroon, and also from United States, but Benin is working in university in the United States and also UK. So I contact them that I have such an idea if they can support the idea. So with the support of the Vice Chancellor, we set up this program. It was very difficult at the beginning, but thanks to the support of the Vice Chancellor, we have tried to attract sponsors like the German Academic Exchange and also the World Bank, which fund students to, let's say, students from sub-Saharan Africa. We have many African nationalities in the program. And of course, the program starts like that. Now, about the question from my colleague from Togo, if such work, modeling work is free or not. Concerning my team, during the COVID crisis in Benin, school and university were closed, and it's like we were annoyed. So what can we do? So the idea is to try to occupy students. So I asked students, master and PhD students and some postdoc, if they want to join a group. I want to constitute to, let's say, analyze COVID-19 data. Is like practical, let's say, practical session for them. So some accept, and we start, let's say, working on the modeling of COVID-19, and we publish some papers. So when the Alexander von Humboldt Foundation launched the call for application, we already have 4 papers in good journals. So we applied them, we have been selected. So now we have found to continue working on COVID-19, and I mean much money. So about 1 million euro is something, right? Thank you.
Yeah, so considering the time, I think we will do the wrap up as the starting session of tomorrow, of next morning, as we also said that we will, talk a bit on the conclusions from the first day then. So if there are no further questions at the moment, contributions to the debate, and I've observed the participants here for quite a while, and I would say we can close the first day. Dinner is already waiting for those who are very hungry. Any other remarks from the 2 presidents?
Yeah, tomorrow morning we start at 9 o'clock. And then we will start with the summary. So I think we don't, for this wrap up, we don't really need to summarize everything. Just one thought that I had now, like thinking about capabilities in different West African countries and whether we have to replicate kind of a modeling consortium in every country. Probably that doesn't work. On the other hand, like from a health systems perspective, I believe policymakers will have much more trust if they get advice from national modelers. So maybe rather thinking about kind of a West African modeling consortium with one modeler per country, but who work together to have this kind of critical mass of modelers who can work together in modeling could be one approach. And maybe G-WAC could also support such a the establishment of such a modeling consortium, because we have grants to invite researchers from different countries to spend time at G-WAC, or we could maybe invite you to give a short course on modeling, which brings together modelers from different West African countries. And I think we can talk more about this maybe tomorrow.
During the COVID pandemic, there was actually not really an open call, but there were a bunch of different modeling groups that were asked to support during the pandemic. And Theo and myself were in one team. And there were a bunch of other teams that looked at some modeling. There were several meetings and discussions and around the modeling. This was spearheaded by the Ghana Academy of Arts and Sciences, made some of the data available, but this data unfortunately was not complete, and we had to go and search for our own data in innovative ways to do the modeling. But as Theophilus stated earlier, I mean, if the data is not really reflective or complete enough, then you do some modeling, but to what extent is it useful? So I think, yeah, building the capacity is so critical, but then as we've already discussed earlier today, having the better data is even more critical, because if you have the capacity but or the tools and nothing to work on, then you really don't get the outcome that you desire. So.
All right, very good. I just had one question from Reinhard. He asked me whether we want to have dinner now at 6 or rather start dinner at 7. I wanted to hear kind of, is there 7? 7, so we go, okay, sounds good. So we go for dinner together at 7, down at the restaurant, and then that's good.
Yeah, maybe Patricia,
Yeah,
I don't know if there any.
thanks again, of course, to all the speakers of this session, to the 2 present here and the 2 in their homes.
So thank you very much, everybody. And we finished this day, and I look forward to continuing this discussions tomorrow with all of you here, and to hear more about the input also from the country experiences.
We'll email you an evaluation form for today. We'll send you a link. It's very short. It shouldn't take more than, I mean, if you just want to check boxes, then it should take you less than 3 minutes or 2. Please do so. It's very important for our feedback and also for reporting to our funders. So thank you very much, and see you.